Okay, and we're live. Hey, hello, YouTube world. We are back. Let me turn the camera a little bit. Looks like I'm a little off. Oops. All right. Everybody ready? Are you guys getting the wrap-up emails? Is everybody getting the emails? Okay. If you're not, please see me after class to make sure that you get those wrap-up emails. Even if you're not going through them while we're in the program, after the program, you'll be able to go back, and it really provides a quick way for you to be able to review the information. So all of those links will be important to you. All right. So let me just get some. I'm going to get your scores here in a minute. Let me just get this. All right, so this is going to be chapter 2 and 3 tests. Trying to get my camera to move, but I don't know if this thing is going to work. Yeah, it doesn't look like it's going to work today. I'm saving up for a follow me camera where when I walk, it follows me around the room. Those things are super expensive. Okay. I think I'm ready. Don't use that clock. Apparently. That's wrong. All right. So chapters 2 and 3. When I call your name, tell me your scores or how many you missed. And I'll get to questions after. Maria.
90% chapter 2. Chapter 3, 95.
Thank you. Marva.
So that should be
2 is 90.
90, yeah.
For chapter 2?
Yes.
What about 3?
3, I think I missed about 4.
4? Okay. All right. Katie.
Test 1 is 90.
Thank you.
Test 2 is 100.
Yep.
Test 3 is 100.
Thank you. Jera.
I don't have to take them yet. I forgot to take them.
Oh, okay. That's okay. Good morning.
Good morning, everyone.
Alyssa.
I missed 3 for chapter 2 and 100 on chapter 3.
Okay. So 85 and 100. 85 and 100. Jordan. Jessica.
Which Jessica?
I'm sorry, Jessica N.
Chapter 2, 95 and chapter 3, 100.
Thank you. Edward.
80 and 90.
Thank you. Jeanette.
95 from both.
Thank you. Sheradine.
100 from both.
Thank you. Emily. Jessica S. Brooklyn. Kevin.
I got 3 wrong on chapter 2 and I got 1 wrong on chapter 3.
Okay, do you have one for me by any chance?
Yeah. I got 100 on that.
Thank you. All right, those of you that missed a question or two, do you understand why your answer was not the right answer? Do you have any questions for me? Do you want me to explain anything to you?
With me is that I had to work this weekend and I really didn't get a chance to do much reading, so I know the reason why.
Okay.
Yeah, so I just did it on my own without doing much.
Without doing the reading, yeah. Yeah. All right. Anybody else have any questions? No? Okay. Tonight you have chapter 4. Chapter 4 is a little bit complex. It's going to go over body systems. And there's a lot of content in there. Don't get too tied up in what body systems are made of. Like, you don't need to know respiratory system is made up of the mouth, the pharynx, the larynx, the bronchial. You don't need to know all that. That's not a CNA modality. But what you do need to know are the normal signs of aging for each body system, because our bodies are kind of like factories. If I invented this thing, right? This thingamajig, whatever it is, and I wanted to have it produced, I would have to go to a factory to have it made. Well, if I toured a factory that was brand new, state of the art, everything shiny, worked great, high production, high quality, because it was all brand new. Or I looked at a factory that was 90 years old, broken down, the springs were rusted, it only worked part-time, and the stuff that it pushed out wasn't all that great quality. Which factory do you think I would want?
Well, it's new.
Yeah, the one that's going to give me the best quality, right?
Yeah.
All right. Well, our bodies are factories, and we really don't stop and think about that. So, like, your liver filters all of your blood, and it does it 24 hours a day, 7 days a week for your entire life. So when it's new, it's going to be very high quality. Everything's going to work really well. It's going to do a really good job. But as that liver ages and we get up into our 70s, 80s, and 90s, that liver isn't going to work as well because it's an older organ. Make sense? So as we age, every body system in our body is going to be affected because your brain has a very specific function. But as your brain gets older, it's not able to perform that function as efficiently. Your stomach has a very specific function, but as it ages, it's not going to perform as it did when it was 12. Does that make sense? Okay. So I want you to pay attention to the normal signs of aging, because if you remember on class 1, we learned that we are there to follow the care plan and observe for any abnormalities. Well, if you don't know what normal is, then how are you going to recognize something that's abnormal, right? So that's what I want you to get out of chapter 4. That's what I want you to focus on. And we are going to review at the beginning of the next class. Good morning. We're going to review the different body systems and the changes of aging that are most commonly seen. Okay, good. Questions on that? All right. So let's review, because the weekend was a very long stretch of time, and I want to make sure that we're all on the same page before I start giving you some new stuff. So how do we know what to do with each patient? So we're going to follow the care plan. Let me turn this a little bit, just so at home they're able to see the whole screen. Okay, we're going to follow that care plan. And it's not just the care plan. We're going to follow the care plan, the whole care plan, and nothing but the care plan. While we're doing that, we're going to make some observations. And then what do you want to do with those observations? Report them to the nurse. Very good. Great job. All right, every skill starts with an opening. What does every opening start with? A knock. Very good. After you've knocked, we want to greet the resident. And we're going to greet them very specifically. How are we going to greet them? By name. Very good. Very good. Now, what do they need to know about us?
What we do.
Name and title. Very good. And then what are we going to tell them? What information do we need to give them? What we're going to do. And we have to do that so that we can get permission. Very good. Once we get permission, then we can provide some privacy. We'll close that curtain. Is that curtain clean?
No.
So what do you want to do after?
Wash your hands.
Wash your hands. Now, once you've washed your hands, you can go get those clean supplies. So everybody good on that order? Okay. The biggest thing to remember about the opening is you cannot touch the patient until your hands are clean. Very good. Very good. So if you watch some of the YouTube videos out there, this just really cracks me up. And there's a couple of people out there that will hand the patient the call light before they go wash their hands. And it's like, okay, let's break this down a second. First of all, our gold rule is we can't touch the patient until our hands are clean. So that violates this, right? Handing the patient the call light is going to violate this principle. But what is the purpose of a call light?
It's for the patient to use the cloth.
If the patient needs something, they can call.
Right. So if you're out of the room, if the patient needs something, they can summon help. If you're in the room, you're already there. They don't need the call light while you're in the room. Does that make sense? So those videos actually show that the instructor hasn't really thought this through. Does that make sense? The patient does not need the call light while you're in the room. They need the call light once you leave the room. Okay. All right. Good. Okay. So let's talk about gloves. When do we need to use gloves? What are our 3 rules? If we're going to touch, okay, personal skin and non-intact skin. So body fluids, personal skin, and non-intact skin. And our cardinal rule for wearing gloves is the first thing our gloves should touch is the patient. That keeps your gloves clean for the patient, which is super important. What kind of gloves would you want to be touched with? But then we have to pay attention to what our gloves touch in the environment. You don't want to cross-contaminate. Be really careful. Once your gloves have touched those patients, you don't want to touch a lot of other stuff in the environment, right? So we want to be careful about what our gloves are touching. And then we have to remove our gloves correctly at the end. And this is going to be graded. Now, a question I get asked a lot in class and on YouTube is, are you graded on wearing gloves? And the answer is actually no. You're graded on wearing gloves if you're going to be touching body fluids, yes. Okay, they want to see that you understand infection control. But let's say that you're taking a pulse and you go and grab a set of gloves for whatever reason. You just decide you're going to wear them. That's not going to count for you. It's not going to count against you. It's just not going to count. What is going to count is how you take them off. So if you're wearing gloves when you don't need it, you've actually added a checkpoint onto your grade that could potentially fail you. So be careful about adding things in that you don't need on the state exam. Okay? So when we take our gloves off, skin can touch skin. Skin cannot touch glove. So we want to pinch up, pull off, and then go under and pull off.
So you're supposed to touch the patient before you touch anything else. When you get your gloves on, do you get graded on that as well? Like if you touch something with your gloves on, that's not the patient?
Yes. And the reason is, let me give you an example. Okay. So let's say that we are going to brush somebody's teeth. Okay. And we do our opening, we go wash our hands, and we get our gloves on. And then we open the drawer to get the toothpaste and the toothbrush and the basin. We go over to Clean Supply, and we reach our gloves into Clean Supply to get our towel. all of that is contaminating those gloves before we put them in the patient's mouth.
So they would mark you off.
They'd mark you off on infection control, certainly.
Adding 2 grades.
Right. Yeah, exactly. Exactly. So infection control is going to count on the state exam. And just think about it from your point of view. If you were the one in the bed, if somebody were brushing your teeth, do you want them to touch a bunch of stuff with those gloves, especially in a clinical environment where you know that that bed was used by somebody else yesterday and there's all kinds of pathogens in the area, right? It's a little different than at home. At home, it's just your cooties. You know, you don't really care too much. But in a clinical setting, man, you're sharing cooties with whoever else has been in that room. Okay. Does that make sense? Okay. To me, I kind of put it in the same category as if you go to a hotel, you know, you definitely want clean sheets. You don't want sheets that somebody else slept on, right? Because that's just gross, right? Well, it's the same thing in a clinical setting. If you put gloves on and you touch a bunch of stuff, it's that level of gross. Right? Okay. All right. So Angel asked, will definitions be on the exam? That's a great question, Angel. And the answer is no. They're not going to ask you what is a decubitus ulcer. There's not going to be a question on the state exam. By the way, that's a bed sore. Just a fancy. Remember, in healthcare, everything has 2 names, right? So they're not going to ask you what is a whatever, right? They don't do that. What they do is the test questions are mostly in scenario format. So you would have a question that says, you're caring for a patient with a decubitus ulcer. What is an important step to maintain skin integrity? I don't know. Yeah, get your supply. I'd have to think about the answers, but there's going to be 3 answers that are wrong. The right answer would be eliminate wrinkles, minimize wrinkles under the patient. Okay. But you would have to know what a decubitus ulcer is in order to answer that question. So they don't ask specifically about terminology, but they are going to use it in scenarios. Now, I will tell you that, let me give you some choices, because the 3 choices that are wrong are going to be really wrong. I mean, you would absolutely know that they're not right. So leave the bed elevated at the highest position at the end of the skill. Make sure that the call light is not in the patient's reach. Or use super hot water to bathe the patient. Right? So those are our 3 absolutely wrong answers. So even if you, did not know what a decubitus ulcer is, you could read those answers and know, okay, none of those work. It must be minimizing wrinkles. Okay. And we're going to get to that, by the way. That's something we're going to be focusing on. Anthea asked, which skill do you use 2 sets of gloves? Denture care and bedpan are the 2 skills that we're going to use 2 sets of gloves. We haven't got to either. My guys, just relax. I'm going to get there. You don't need to know that. I'm just answering her question for her. But denture care and bedpan are 2 sets of gloves. All right. So if we're going to use clean supplies, we have to have a place to put them. So we're going to use a barrier. Yeah. And anything can be a barrier. Remember that. We're only going to touch supplies with what kind of hands? Clean hands. And we're not going to let those supplies touch our uniform. Very good. When do we get that barrier? When we get all of our supplies? Before we get our supplies, then we're going to go back and get the supplies. Very good. Because you need 2 hands to spread that out. All right. And then we're going to talk about privacy blanket. So why do we use privacy blankets? Okay. So privacy blankets are going to do 2 things specifically. They're going to keep the patient warm and protect their privacy or dignity, right? So how do we know when we should use a privacy blanket? Anybody remember this? When the patient is uncovered or undressed. Very good. Very good. So a question I get asked a lot is, well, do I need a privacy blanket for this skill? So range of motion, do I need a privacy blanket for this skill? It's not based on the skill. It's based on the patient. If they're going to be uncovered or undressed at any time, then we've got to use a privacy blanket. Okay. Remember, everything always comes back to the patient. Yeah. When we put the privacy blanket on, are we going to take the sheet all the way off the bed first and then put the blanket on? No, we want to put the blanket over the sheet and then pull the sheet down underneath. That way the patient always remains covered. Yep. And what can we not do when we're putting that blanket on? Shake it or snap it. Very good. Very good. And then at the end of the skill, when we're going to remove that blanket, do we remove that blanket before or after we take our gloves off? Before or after we take our gloves off. That sheet is going to go right up next to their face. And we have to have them covered at all times. So if you take that blanket off and you pull the sheet up right next to their face with dirty gloves, they're then going to be breathing in all of those pathogens. So we don't want that. We want to take our gloves off before we remove the privacy blanket. Good? Makes sense?
You wash your hands after you take off the gloves.
You don't have to. You don't have to. You can if you want to, but you don't have to because it's the patient's cooties. But we don't want to grossly contaminate that sheet. The patient's in bed. They've already contaminated the sheet, but we don't want to grossly contaminate it.
Right.
The sheet that we will pull down, but for example, we are bathing the patient, we're gonna remove it, put in a dirty basket, and bring a new one when we're done.
No,
It will be reused.
no, that's why we're going to use the privacy blanket because the blanket is going to cover the patient throughout the process, keep them warm, keep them private, but the blanket is what we're going to remove at the end of the skill, not the sheet. We'll just pull the sheet back up. Okay, I'm going to sit, guys. My knee is hurting. All right. So let's move on to linen rules. Now, we didn't go over all of linen rules. There's still 2 that we did not cover. But let's cover the ones that we did. Now, all of these are repeats that we've already learned. So what can't touch your uniform? Supplies, linens, anything. Yeah, nothing can touch your uniform. And what kind of hands do you need to get those supplies? Clean. Okay, so we've covered those. What aren't we going to do with your linens? Shake them or snap them. So we've covered that too. This was new though. Anything we don't use, what do we do with it? Yeah, dispose of it. Don't leave it in the room till later. If it's out of your sight, it's not clean. The other 2 we're going to get to in just a little while. We're going to fill in these gaps in a little while. Okay. And then the closing we learned. A good rule here is just leave your patient looking better than you found them. I've always used this principle in my nursing. I always leave my patients looking better than I found them. That may mean straightening the sheets up or, kind of cleaning up the table before I leave or taking out the trash or whatever I need to do to get my patient's environment looking better than I found it. If everybody does this, the unit stays clean. It's that simple. But patients will rest better in a tidy, orderly environment. The other problem with this is families. Okay. If a family comes into the room and the trash is overflowing and the breakfast tray hasn't been removed and it's now 11:30 and you've got food just sitting there rotting, and you've got the table all junked up and the patient's sheet is on the floor, is that family going to feel like you're taking good care of their family members? No. So a lot of this has to do with the patient. We want the patient to rest well, but some of it has to do with the perception of care that's being provided. And that's why we have to take a minute to look around and make sure the environment is clean. For the test, you don't have to say anything about this. I like to, your environment's clean, just to remind myself that that's a step. Okay, clean and safe. What position does the bed need to be in? Lowest position. Why is that important?
Safety.
Safety, very good.
Do they use bed rails anymore?
We're going to talk about side rails today.
Okay.
Yep, we'll talk about side rails. What word do they need to hear?
Comfortable.
Comfortable.
Anything else before?
Yes, and you really do want to ask, do you need anything else? Don't rush out because it's going to save you a ton of time. I'm telling you, if you implement that, it will save you a ton of time in your workflow. Preferences, at the end of the skill, the more comfortable you can get them, the less they're going to be on that call light. So give them something to do. Give them a crossword puzzle book, a magazine, TV remote, their cell phone. I don't care. Give them something to do. Make sure that the head of the bed is in whatever position they want it to be in. Maybe they want to sit up, watch TV. Maybe they want to lay down and take a nap. How do they want to be left? So preferences are going to be important here. Patients must be covered when we leave them, either with clothing or a sheet, but don't leave your patient out there uncovered at the end of the skill, unless that's what they want. Okay. Sometimes patients get hot and they'll kick that sheet off, but for the test, we want to make sure they're covered. At the end of the skill, we're going to open that curtain because we don't need it anymore. Let me talk to you about this real quick. This is actually going to fall under preferences in a clinical setting. So some patients are going to want that curtain closed. They're going to want to kind of block out, the world. They're focusing on themselves. But for the test, we're going to open the curtain. Now, in a clinical setting, I'm going to tell you that whenever possible, we want that curtain open. First of all, it's a visibility issue. If the curtain is closed all the time, we have no idea what's happening behind it. We can't see. And that patient may be being physically accosted by another patient or a staff member. So having the curtain closed all the time can be a safety issue because you can't see past that curtain. The other problem with curtains being closed all the time is that it tends to lead to depression because patients are very self-absorbed. They've got a lot going on. If they're focused on themselves, have you ever been too much in your head? Too much in your head is a bad place to be, people. It is a bad place to be. We're also social creatures. So if that curtain is closed all the time, it tends to isolate the patient. So there's a lot of really good reasons that we don't want that curtain closed all the time. Now, if the patient's asking, oh my gosh, I've got a headache, can you just close the curtain? I just don't want light right now. That's fine. Leave the curtain closed, but who do you think you should tell?
The nurse.
The nurse. That's right. That's right. So for the test, we're going to open the curtain.
If they're consistently asking for it to be closed over and over again, do you just tell the nurse?
Absolutely.
Close it and just go to the nurse?
Yep, absolutely. And let the nurse figure out the why behind that action. As a nurse, if you come to me and say, hey, that patient wants their curtain closed all the time, I'm going to go in and have a little conversation with the patient and try to gauge their mood, their mindset, their pain level, what's going on with them, because there may be something there that is going to affect how we perform our skills. Or I may need a site consult. Remember that changes require adaptation. When your health changes, it requires adaptation. A lot of people don't have good coping mechanisms. Have you ever met somebody that didn't have a good coping mechanism? Yeah. They may get withdrawn or depressed. They may get angry and lash out. They may get stubborn and entrenched. This is the only way I'm going to do it. Change requires adaptation. And when we are working with patients, guys, these people have had a tremendous change. Not just a change in their health, that's bad enough. Guys, I am dealing with a change in my health. My knee is killing me. Okay. I can't do the things I used to do. That is affecting every part of my life. That is a huge inconvenience for me because I'm a pretty active person. And I'm having to deal with those changes to the point that I'm actually thinking about giving up my car because getting in and out of that car is difficult on me. I love my car. You have no idea. I love my car. This is a huge deal for me. But I have to adapt, right? Because I've got to change. Well, when we're dealing with patients, it's not just their health that's changing. It's their ability to work. It's their time away from their family. Who is feeding their puppy at home, right? They're not there. What are their significant others doing at home? How am I going to pay this bill? And for those in long-term care, they had to give up their home. They had to sell their home and all of their possessions. You don't think that that requires some adaptation, right? Because when you think about retirement, I want y'all to stop and think for just a second about what you think your retirement is going to be. And it's probably sitting on a beach somewhere, freedom to do what you want, right? Floating in your pool, drinking your Mai Tais, maybe playing golf, maybe playing with your grandkids, right? Those are all the things that you think about when you think about retirement. You are not thinking about your health going to crap and moving into a long-term care facility and letting somebody else wipe your butt. That is not what you have in mind for retirement. Those patients didn't have that in mind either. So do you think it's possible that some of these people are going to be angry over the situation they find themselves in or depressed? So those are things that as the nurse, I have to think about. So when you come to me and you tell me, hey, this patient wants the privacy curtain closed all the time, I have this knowledge. I know that their life is just took a sudden left turn. It went totally off the rails. It is not going the direction that they thought it was going to go. Could they be depressed? Sure. And now that's something that I can help intervene with. Maybe they need a friendly person to talk it out. Maybe they need a psych consult to help with coping mechanisms. Maybe we need a plan. Does that make sense? And if you think this doesn't get serious, let me explain to you how serious this gets. Our local rehab hospital about 3 years ago had a husband come in, shoot his wife in the head in the rehab center, and then go out to the parking lot and shoot himself. Let me tell you guys, this gets real. So something as simple as the patient wants privacy curtain closed all the time, that is a real clue. This isn't kid stuff. When I say that you have to report everything to the nurse, I mean everything. Does that make sense?
What if your nurse is like constantly busy and shopping you off?
I wish I could tell you that's not going to happen, but it does way too often. Go up your chain of command.
Won't that get you fired?
Not if you go up your chain of command. Don't go directly to the DON. Go up your chain of command. So whoever, usually the unit supervisor, charge nurse, yep. Hey, I'm just letting you know, I told my nurse this, but I just am not real sure it's being addressed. You know, this patient is showing signs that they might be depressed, and I just don't want anything bad to happen to them. You know, just kind of address it that way. Ultimately, you are not responsible for the nurse's reactions or lack of reaction. You can do the best you can. Make your concerns known, but at the end of the day, it's on them. Remember, they hold the liability. And they're the ones that have to sleep with themselves at night and look at themselves in the mirror. So if they miss something and something tragic happens, that's on them, morally and legally. You've done your job. Okay.
I have a question. So what if we're actually in a room with a patient is doing some type of self-harm? We're not to leave the patient alone, and we use the call light to get the attention of a nurse, and they don't respond.
Yeah, don't use the call light. Call light's not going to help you a bit because nurses will sit back and wait for the CNAs to answer the call light. So call light isn't going to help you. A very loud staff. Never yell help. This is a very good tip in a clinical setting. Never yell help. Your patients are all yelling help. Staff will tune that out, especially if you're working in dementia units, because every dementia patient yells help. That's not going to help you. But if you yell out, I need staff stat, that tells them that there's a situation going on. And the neat thing about a lot of work goes into designing clinical settings. You probably don't know this, but when they design clinical settings, it's a whole different type of architecture. And there are actual studies that are done that place nurses stations within so many feet of patient rooms. So you are never out of earshot of a staff member, unless you're working in home care. That's a whole different beast. But if you're in a clinical setting, you are never out of earshot of another staff member. So you want to yell loudly, but never yell help, because help will get ignored. You want to yell staff needed, staff assistance, something like that. Staff stat. Every facility will have a code that you can yell out. Some places are code orange. Some places are hospitals will use a specific doctor name. It's not like an actual doctor, but they'll, just for instance, Dr. McStuffins. I know that's not it, but that you can yell out, and that tells everybody that there is a crisis happening with staff. So you would want to find out during orientation what your code is for that. Okay. Yeah, it won't be McStuffins, but I was just using that as an example. So does that kind of make sense? So when we're talking about privacy curtains, I know it sounds like such a small little detail, but it really can tell us a little bit about the patient. And a good nurse will always care what you have to say. Always. Because you know the patients way better than I do. You spend way more time with the patients than I do. On average, a CNA will spend about 2 hours a day with the patient. A nurse spends less than 7 minutes. So you guys know way more about these patients than I do. So if you come to me and you tell me, hey, Mr. McGillicuddy's not eating real well. Like, I'm taking his tray in and he just doesn't really seem to be eating a whole lot. As a good nurse, I'm going to look into that. I'm not just going to write it down and move on. I want to find out, why is he not eating well? Sure, it could be because he's depressed. Yeah, it could. But it also could be because his dentures are at home and he doesn't have them with him. It could be because he's suddenly developing swallowing difficulties, which might indicate that we are working up to a stroke, right? So there's a lot of reasons why Mr. McGillicuddy may not be eating really well. It's up to me to figure out all the potential and the real problems and develop a plan. But as a good nurse, I will listen to you. So if your nurse isn't listening to you, judge accordingly. Okay. How many of you guys think that you might go on into nursing? Okay. Everything that I'm telling you I want you to remember, this is the foundation for nursing. Everything that I'm telling you will make you a good nurse. And when you are a nurse, take care of your CNAs because your CNAs can make or break you. Okay? I believe firmly that everybody should travel the same route. CNA, LPN, RN. I don't think that there should be any other way to be a nurse. And I know we've got a million nurses, and I'm talking to you guys out there because you know who you are. You go through a 4-year BSN program, you do some clinicals, but you think that bedpans are beneath you. They are not. You help the CNAs when you can. But on the other hand, you guys need to free up the nurses to do those higher level tasks as well. So we all work together as a team, but we all have our roles. If the nurse is helping you so much that they can't get their job done, it's not going to get done because there's nobody else to help them. Okay. You will be the right hand of a good nurse. But when you're the nurse, remember, treat your CNAs well because they can make or break you. And those nurses that forget that, they are on my list because we need to be a team. Remember, I told you on day 1, if you ever find that it's you versus the nurse, the patient is the one that's going to lose every time. Every time. So if you find yourself in that situation, go find a different place to work because you're not doing your patients any good. You're just not. Okay. I've worked with some nurses like that. I left a job over a supervisor like that. I flat out quit. So they're out there. But those of you who go on to be nurses, don't be one. We need better nurses. Okay. All right. So we're going to open that privacy curtain at the end of the skill and give the patient their call light and instructions. Once you've done all of that, the order doesn't matter. Do it any way you want to. You know, the environment's clean, the bed's in the low position. Here's your call light. Open the curtain. Is there anything else that you need? Are you comfortable? Once you get done with all of that, go wash your hands because we want to wash those cooties off, right? Patient cooties, get rid of them. Once you've washed your hands, though, can you come back over to the patient and do stuff like give them their call light? No, why? Yeah, you're recooting up. Absolutely. So at the end of the skill, if you're over at the sink washing your hands and you realize, I forgot to get the call light, and you go back and you give the patient, don't ignore it. Trust me, those evaluators saw it. Okay, so go back and give them their call light, but make sure that you wash your hands again. Okay, good.
I have a question about supplies. After we wash hands, we get our supplies, but if they're under the sink and we have to open the door, we should grab paper towels to open the doors to get them.
You can if you want to, but the supplies shouldn't be under the sink. Actually, in a clinical setting, nothing should be under the sink. But they may be in the drawer unit like this, and you can grab a paper towel. But at the end of you're going to see this in a few minutes. But at the end of the skill, anything we put back, we're going to use a paper towel. So our hands before we wash them are not going to touch this. So theoretically, this should stay pretty clean. Okay. But you can always use a paper towel to open anything. If in doubt, use a paper towel. If in doubt, use a paper towel. Okay. If we have to document, we will do that at the very end. After everything has been done and we've washed our hands, then we will document. But when we document, we want to make sure, because we don't know if this pen is clean. We have no idea. It's been in our pocket. If we document, we have to wash our hands again because our standard is end skill with clean hands. End skill with clean hands. Okay. And don't return to that patient. All right. We also learned how to take a pulse. Do you guys remember this? how to take a pulse. So when we're taking the pulse, what has to be supported? Yeah, don't leave that arm hanging out in midair. What time period is a pulse always reported over? 1 minute. Now, it doesn't mean we have to count for the whole minute. We can do a shortcut, right? We can count for 15 seconds and multiply that by 4 to get our full minute, but it's always reported over a minute. So if I tell you a pulse rate was 72, that means the patient's heart beat 72 times a minute, right? Doesn't matter how I get that number. If I tell you a pulse rate is 68, the patient's heart beats 68 times a minute. How do we know how long we should be counting for, though? Care plan, right. So we're going to follow that care plan. What is a normal pulse rate? 60 to 100. I'm going to tell you, you will have at least one, but probably two vital signs questions on the state exam. So one of them may ask you, what is a normal pulse rate? But more likely, they're going to give you a whole bunch of vital signs and ask you which one you would need to report to the nurse. Okay, so you've got to be able to look at all those vital signs and find the one that needs to be reported. Make sense? Okay, you will have at least one, but probably two vital signs questions on the state exam. And this goes right back to we are required to report anything abnormal. Well, if you don't know what normal is, how are you going to recognize abnormal? And that's what the test is getting to. A lot of the test is going to be about that. What area of our fingers do we want to use? The flat part or the tips? The tips. And where should our thumb be? Yeah, on the back of the wrist. Can we use our thumb to take a pulse?
No.
Why? Yeah, you'll get your own pulse. Doesn't help. Where is a radial pulse located? Okay, wrist. But is it at the thumb side or the pinky side? Thumb side of the wrist. Okay. When we're counting with the evaluators, how are they going to know when we are counting? Okay, so you're going to say out loud, start when you start counting, and you're going to say stop when you stop counting. That way they start when you start and they stop when you stop, and hopefully they're going to get the same readings. Now you can be off for the test. You can be off by 4 beats in either direction. But if you're not telling them when you start and when you stop, that doesn't help them identify your pulse rate.
You're going to be on one wrist and the result will be on the other one?
Yep. And this is one of the skills where they're like really close to you. So that ramps up your anxiety, right? Because they're like right there. But there's 2 evaluators for the state exam. Patient only has 2 arms. You got one of them. And the evaluator has the other one. So this skill you actually have to do twice. You have to count with each evaluator.
But you want to count to yourself. You say start and then count to yourself.
Right. You want to count to yourself. You don't count out loud because that's really weird for the patient.
Right.
Let's think about that from the patient point of view for a second. So if you're standing there counting out loud, 26, 27, 28, 29, 30, 31, 32, you'll actually notice their pulse rate will start to increase because this is a minute. This is a long time, people, right? So as those numbers get higher, they're starting to think, is this normal? Am I okay? What's wrong with me? Why are they still counting? Oh my gosh. And that increases the anxiety, which is going to increase the heart rate. So you're not going to get an accurate reading. If I'm counting for 1 full minute, I tell my patients because a minute is a long time. So if I find the pulse rate, right, and I know I'm going to count for a minute, I'm going to let the patient know, hey, this is going to take me a minute. I'll need you to remain quiet, but I'll let you know as soon as I'm done. If you do that, then they're expecting it to last a minute. They don't get all anxious. But if you're counting for a full minute and they don't know what you're doing, you're just standing there quietly holding their hand, they're going to be like, what's going on? Is everything okay? Am I all right? Is this normal? And what do you think it's going to do to your count? Yeah, because they're talking. They're yapping. We don't want them yapping. So if you tell them ahead of time, hey, this is going to take me a minute. I got to count for a minute. I'll let you know when I'm done. They normally will stay pretty quiet for you. People start talking when they're nervous and when they don't know what else to do. Okay. It's a great interrogation technique. And if you want to get information from somebody,
Make them nervous.
make them nervous, but don't say anything. Just
Stare them down.
they will start talking. Yeah, it's a great interrogation technique.
Does it work with husbands too?
It does. If you can get their attention, you got to get them off of March Madness first. All right. Because we're counting something, what do we have to do after we count something? Yeah, we're going to wash our hands and document it. Yep. Having it up here does not help the nurse.
So do you want to wash your hands right after you take the pulse before you document, or document and then wash your hands? Because you're touching that pen.
Right. Both.
Oh,
You're going to wash your hands,
okay.
document, and wash your hands again.
Okay.
Wash your hands, document, wash your hands
Can
again.
you just put a pair of gloves on before you do the pulse?
You can. Like I said, gloves aren't graded whether you use them or not, but you will be graded on how you remove them. Now, I will tell you that the evaluators may tell you you don't need gloves for this. And part of that is supplies. So something we didn't talk about with gloves real quick. Let me go over this really quickly with you because this is kind of important. What happens to gloves after you wear them?
Throw them away.
Hey, you throw them away, right? Have you ever stopped to think about what happens to them after that?
They get thrown in the ocean.
Okay, in some cases, yeah. But they have to go somewhere, right?
Mhm.
Well, in America, and just healthcare, I'm not talking about housekeeping, vet, industrial. I'm not talking about any of that, just healthcare. We use enough gloves in healthcare in this nation to fill a football stadium 35 feet deep with gloves every day. Every day. Now, latex gloves are biodegradable. They will break down, but it takes a very long time to break them down.
You don't see latex anymore.
No,
Everything's vinyl.
right. Everything. That's right. Latex gloves are biodegradable, but the others, the nitrile gloves and the vinyl gloves are not, which means that every pair of gloves that you put on is going to be on this planet in 100,000 years.
Why did they switch then?
Because of allergies. The more exposure you have to latex, the more likely you are to develop a latex allergy. So nitrile and vinyl are the industry standard now. The problem is that they're not biodegradable. So we have to think about environmental impact here. And I'm not a tree hugger. Okay. I drive a gas guzzler because I like speed. Okay. Yeah, I do. I absolutely do. I don't recycle, right? I don't do all the things you're supposed to do. I'm not an environmentalist, but this really does kind of impact me, knowing that putting on a pair of gloves that I don't need is something my granddaughter is going to have to deal with at some point in her life. Because they can't just, we can't just keep stockpiling these things. They've got to go somewhere. And if you've ever watched the movie WALL-E, anybody ever watched the movie WALL-E? Yeah, do that this weekend. Watch WALL-E. At the very beginning of WALL-E, it's a cartoon. It's really cute. It's about two robots fall in love. It's cute. But at the very beginning, all the humans had to leave Earth because it was overrun with trash. And a lot of the trash is medical waste. And little WALL-E, his job is to kind of get rid of the trash so the humans can come back to Earth. But it's a cute movie. But the whole purpose of it is to make us aware of what we're doing to the planet with all this disposable stuff. So it's just something to kind of be aware of, right? So wearing gloves when you don't need them is contributing to a problem that's already big enough. We don't need to contribute to it more. The other problem is cost. Gloves cost money. Who do you think's paying for those gloves that you're wearing? Well, indirectly,
Yeah.
but the employer is going to pay for it, right? They're buying the gloves, and they're putting significant amounts of money into gloves. Gloves, the cost of gloves went up like 10 times over COVID. Like what I was paying for a box of gloves before COVID and what I'm paying now is insane. So if your facility is spending all this money on gloves when they don't need to, do you really think you're going to be getting a raise? They're running out of money, guys. The CEOs aren't, but they're not going to give up their bonuses. So they're running out of money. So we've got to be a little bit smarter about the choices that we make. Does that make sense? So during the exam, if you go to grab a set of gloves that you don't need, the evaluators may tell you, you don't need those gloves for this skill. Now that'll throw your skill off because now you're really nervous. Now you're like, oh, is this a trick? What, can I still wear them? She said, I don't need them, but can I still put them on? I don't know what to do now. Right. So you got to throw them away. Yeah.
But they shouldn't say anything because if you already have on your hand, then it just gonna just waste.
They'll
anyways.
probably, if you go to reach for the gloves, they'll probably stop you before you get there. But that's because the supplies cost money. Okay. Does that kind of make sense? Good.
Aren't you supposed to wash your hands after you take off your gloves?
Yes, but you don't have to wash your hands right after you take them off. You can wait until the end of the skill because the whatever got through the gloves onto your hands, those cooties, for lack of a better word, right? Those are the patient's cooties. They're already all over the environment. So you're not, it's the what we call gross contamination. It's the body fluids we don't want to spread around. Okay. Cooties are okay, just not body fluids. All right. So we also learned how to dress a resident with a weak arm. So what do we want to ask the patient before we get them dressed? What do they want to wear? Sure, absolutely. And when do we want to get that clothing? Before or after we undress our patient? Before. That's right. We want to minimize the time that they're exposed. If we're going to lift any extremity, how do we lift it? From above or from below? From below. Okay. You want to support all the joints. Very good. How do we undress a patient that has a weak arm? Which arm gets undressed first? Strong arm. Which arm gets dressed first? The weak arm. Okay. And then we don't want to overextend or force movement. Remember, don't break your patient's ankle for the test, please. At the end of the skill, you need to adjust the clothing to make sure it's neat. They're presentable. Anything that we don't use, where does it go? Okay. Anything that came off of the patient, where does it go? Yeah, in the hamper. Okay. And which hand do we want to put the call light in? Stronger hand. We also learned range of motion. Remember that CNAs do range of motion to retain function, basically maintain what they've already got going on. And again, how do we lift?
Underneath.
From below with a flat palm. You want to support near the joints. We're going to move slowly and smoothly, but we always have to return to starting position. Very good. Flexion extension is what kind of a motion?
Up and down.
Up and down. Abduction, adduction,
Side to side.
and rotation is
Around.
around. So USA, up, down, side, side, around. All right, so look at how much we've learned. Look at how much we've learned. We're going to learn more today. We're going to fill in the rest of linen rules. We're going to talk about scoot and roll. We're going to talk about washing rules and basin cleaning. So we have a long way to go today. So let's start with hand and nail care. This is on page 116 of your book. Lot of principles involved here. A lot of principles. We're going to follow the care plan. We're going to do our opening. We're going to evaluate if we need gloves. We're going to use a barrier. Linen rules are going to apply. Washing rules. Basin cleaning. Skills specific. And the closing. So this skill has a lot of steps. If you look on page 117, you can see all the steps listed there for you. Now, when you guys are practicing, the best way to practice is in groups of 3. One person is the patient. One person is doing the skill. The third person should have the book and be following along all the steps. And that way they can tell the person that's practicing what to do when they get stuck, but also they can tell them when something is not being done correctly. Okay? So these step-by-step instructions help you learn how to practice the skill correctly. It's on page 117. Okay? So far, looking at all of these principles, we know everything but washing rules and basin cleaning. So let's learn those 2. So washing rules are going to be found on page 112. And we're going to use washing rules in these 5 skills: catheter care, foot care, hand and nail care, partial bed bath, and peri care. So the rules that we're going to go over now, we're going to use in a very large percentage of the skills that we do. So let's learn these principles. Page 113 is the notes for everything I'm going to be telling you. How do you guys bathe yourselves? How do you bathe? Okay, top to bottom. All right. You probably shower, right? Or take a bath, right? But you have water. You have soap. What do you do after you put soap on? You rinse it off, right? You wouldn't dream about getting out of the shower with soap still on. You rinse it off. And yet that is the most missed step on the state exam. We tend to forget when we're washing somebody else that they have to be rinsed. So keep that in mind, right? Whatever we wash, we rinse. Whatever we rinse, we dry. Same way you bathe yourselves. But when we bathe somebody else, sometimes we can get kind of lost in the steps. Okay? So we're going to go over some specifics here on how to wash somebody that's not us. All right. So when we bathe, we get completely undressed. We get into the shower or the bathtub, whatever we're going to be using. We soap up, we rinse off, we get out, and we dry off. And then we get ourselves dressed, usually in clean clothes. Well, exactly the same steps are going to be used on a patient, but we're going to have to modify them just a little bit because we're not, in this case, we're not taking the patient to the water source. We're bringing the water source to the patient. So that's going to change things up just a little bit. And we have to think about how we're going to do that. Okay, so how do we bring the the water to the patient. And well, we just went over this. Whatever we wash, we rinse, and whatever we rinse, we dry. So since we have to rinse the patient, that requires clean water. And remember, we're bringing that water to the patient, right? We're not taking the patient to the water. We're bringing it to the patient. So if we put soap in the basin, we don't have rinsing water. Do you guys understand that? If you put soap in the basin, you have no rinsing water. So this is what gets a little confusing for students because, you know, we all grew up taking bubble baths, right? So you put soap in the water. You don't want to do that when you're bathing a patient. No soap in the water. So the way you remember this, our basins are no soap zones. We don't put soap in the water. Now, some people are sitting there thinking, well, just go get another basin. Remember that everything that you use for that patient is going to be billed to that patient. Patients get a bill at the end of their stay. You guys know that? Have you ever been a patient at a hospital? Did you get a bill?
2 bills.
Yeah. Yeah, you probably got several actually. You got bills from doctors, bills from radiology, bills from lab, bills from pharmacy, bills from the hospital, right? But when they give you that bill, they just usually give you a flat rate. You owe $2,576. You have the right to ask for an itemized bill. Okay, how did you come up with that $2,576? And what you'll see is if you get an itemized bill, every single thing that was used on you at that facility was billed to you. These basins are on average about $36 for a piece of plastic. Yeah. We're not talking about Dollar Tree stuff here, guys. Toothbrushes are like 12. So we want to not overly burden our patients with unnecessary items. Does that make sense? Okay. So we have to be good stewards of our patients' money. And there's no need to get 2 basins. You don't need it. Just don't put soap in your water and you've got rinsing water. And we've saved our patient $36. One of the fastest growing segments of nursing, and I love this. This is hilarious to me. When you get that itemized bill from the hospital, you can hire a company to go through that bill and debate anything that is not strictly necessary. And they will take a portion of whatever money they save you. Yeah. Isn't that crazy? So let me tell you, if I'm reviewing a medical bill and I see 6 basins, that's the first thing I'm going to mark off. Nope, 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 nope. And CNAs aren't aware of this. A lot of CNAs, when you use a bedpan with a patient, that bedpan is supposed to be cleaned out. It's plastic. It's supposed to be cleaned, reused. It's only used on that one patient. We don't go passing them patient to patient. Okay. But it's not supposed to be thrown away. A lot of CNAs out there won't clean the bedpans. They'll throw them away and charge the patient the next time. Think about how many times you use the bathroom every day. Can you imagine having to pay like $40 every time you had to go to the bathroom? Yeah.
So that is what caused these bills to be so expensive.
Absolutely.
So it makes sense.
Absolutely. And remember that CNAs are the ones that spend the most time with the patients. We're the ones using the most supplies. So this is why we have to talk about this. Okay. Everything that you check out will be billed to that patient.
So if you're in the hospital, you have to be paying attention to what that CNA is doing and say, okay, so you have to wash this back and put it back.
Right, right. Don't charge me for another bedpan because you have a deductible. I don't know about you guys. My insurance is sky high. My health insurance, I am paying a fortune for health. That's why I can't afford to get my knee fixed. My deductible is $9,000. That is what my deductible is. That means before my insurance kicks in anything, I have to pay $9,000. Yeah, small business guys.
It's rough when it comes to insurance.
It is. It's horrible.
It
It's
is,
horrible.
it is.
So I'm a healthcare provider that can't afford to get healthcare myself. Okay. So if I get my knee fixed, you better bet I'm going to be watching what everybody's billing to me because I'm the one that has to pay for it. Right? Does that make sense? Okay. So we don't add soap to the water in the basin. We keep that water clean for rinsing. Good? Good. All right. So if we're going to get water for the patient, so let me back this up a few minutes, okay? So we've read our care plan. Remember, that's always step one, read that care plan. We know what the care plan tells us to do. We do our opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain, go wash my hands. Now I have clean hands. And I have to have clean hands to go get my supplies. First supply I'm going to get is a barrier. Then I'm going to go get the rest of the supplies I need. So my towels, my washcloth, my basin, my soap, my lotion, my orange stick, my emery board. You do have to learn your supplies, people. You have to learn your supplies. So I get all of that, lay it out on the table. But I have to go get water. Now, I've washed my hands and all I've touched are clean supplies. Do I want to use these hands to touch that faucet? So what could I use between my hands and that faucet to turn the water on? Paper towel. Okay. So I'm going to use a paper towel to turn the water on. Now I'm going to use the inside of my wrist to judge the water temperature. And it should feel warm, not cold, not hot, just warm. But the problem is that my perception of temperature is completely different than my patient's perception of temperature. And let's talk about why. Okay. So use paper towel to turn the faucet on. Sometimes I forget to go through these. Okay. So keep your hands clean, use a barrier. Now, this water needs to be warm, not hot, not cold, just warm. And we're going to ask our patient to check the water temperature too. My perception of temperature is different from my patient's. We also have different preferences. I like hot water when I'm showering. I want it to, I want it to slide the skin off my body, right? I want hot, hot water. My husband hates hot showers. He likes cool showers, right? All of you guys have preferences as well. So remember, this is a preference issue. Just because I like hot doesn't mean I should use hot on the patient. But their physiology is different as well. And we're going to get into that now. So when we're young, our skin layers are thicker. Okay, we've got a layer of skin, a layer of fat, and a layer of muscle, and they're thick. But as we age, all of those layers decrease in thickness. Have you ever seen an older person, like 70, 80 years old? If you look at their hand, you can actually see the veins underneath their skin. And it kind of looks just like skin over bone. I mean, it's like there's nothing there. And those veins are like really ropey, right? You can't, well, you're starting to see it on mine. But I'm getting old. I'll be able to use me as an example soon. But so that tells us that when we're young and we can't see that, but we get old and we can, that a change happened, right? Well, what has changed is the layer of fat underneath your skin layer actually goes away as we age. It gets resorbed. Now, what does that layer of fat do? Well, it actually does a couple of things that's going to affect us. Think of that layer of fat like a wetsuit. Okay. Anybody know what normal body temperature is?
98.
Okay, 98.6. It's usually a range, 97.6 to 99.6. But Let's make it easy. I like easy numbers. Okay, let's just say 98. Okay, 98. If you walk outside and it's 98 degrees, how would you describe that temperature? Hot. 98 is hot. If this room were 98, hot. But you reach over and touch each other, you guys are 98 degrees. We don't think about that, do we? We don't think about that. Now, the important principle here is that room temperature always wins. So if your body is 98 degrees, and remember it's a range, but we're just being easy here, 98 degrees. If your body temperature drops below 95, it's hypothermia. Below 93, you are dead. Now, room temperature always wins though. Room temperature, we like to keep somewhere around 70 to 75. Right? Let's just easy. I like easy numbers. Let's just pick 75. Okay. Room temperature 75. So in order to explain this, we're going to go into the kitchen mentally for a second. If we have a pie that we have baked in the oven at 325 and we pull that pie out of the oven, the pie is hot, 325 degrees, right? Put it on top of your stove and walk away from it for a while. If you come back 3 hours later, is that pie still 325 degrees? No, the pie is probably now closer to room temperature. Now, to go along with that pie, we're going to reach into the freezer and grab a thing of ice cream out. When you grab the thing of ice cream out, it's going to be about 0 degrees, okay? Somewhere under 32. And as long as it just came out of the freezer, it's still going to be freezing. Leave that ice cream on the counter for 3 hours. If you come back, is it still freezing? What happened? It melted. It came up to room temperature. Guys, room temperature always wins. Always wins. So how in the world are we 30 degrees or 40 degrees above room temperature? If room temperature always wins. What that means is your body has to continuously generate heat to keep you at 98 degrees. And that is the main reason you eat, by the way. It's not for nutrition, although we get nutrition out of it. You eat to have calories to burn. That's what we call it, burn, because it generates heat. That heat is what keeps you at a living temperature. Make sense? Because room temperature always wins. Got it? All right. So when we're young, we have this wetsuit on. We have this layer of fat. And that layer of fat actually holds in that body heat. It keeps it from radiating away. So your body doesn't have to work as hard to stay at a living temperature. Make sense? It also blocks out external temperature. It keeps the room from cooling you down so quickly. It keeps outside heat from heating you up to overheating. It protects you. It holds your body heat in and helps block out external temperature changes. Good? Now, remember, I said that this is the one thing that goes away as we age, this layer of fat. That means that our older individuals' bodies are going to have to work harder to maintain their body temperature. And they're probably not going to be all that efficient at it because remember, their body heat factories are 70, 80, 90 years old. So have you ever seen an older person in an environment with a sweater on and you're like, oh my gosh, why are you wearing a sweater? Right? It's because their body temperature it's difficult to maintain at 98 degrees because they don't have that layer of protection. Does that make sense? This is why grandma's house is always so hot. It's also why a lot of people retire to Florida. They will say, I can't handle the cold up north anymore. And they truly can't, because that layer of fat is no longer there to block out those external temperatures. Remember that you guys are feeling those temperatures through a wetsuit. That effect is being minimized. Does that make sense? This is also going to affect how your patients feel water temperature, because that layer of fat also acts as an insulator. So when you have water running on your body, you're not getting the full effect of it, because that layer of fat is help minimizing the effect. So if I get water and I feel the temperature and it feels just fine to me, that patient may have a totally different perception of it, because they don't have the same insulating layer that I do. Does that make sense? Okay. So anytime we get water for a patient's use, we're going to check it with the inside of our wrist, and it should feel warm, but we're always going to ask our patient to check it as well. And if the patient says, oh no, that's too cold, go warm it up. If they say, oh no, that's too hot, don't argue with them. Go cool it down. Help isn't help if it doesn't help, right? Probably one of the worst CNA experiences I had when I was a nurse. I was sitting at the nurse's station documenting something. I have no idea what, but I started hearing this screaming coming from the shower room down the hall. And I go down there thinking somebody fell, something happened. I open the door and steam comes billowing out. My glasses fogged up. I couldn't see anything for a few minutes. Finally, when everything cleared and I was able to kind of see in there, CNA is fighting off a patient trying to push her into the water stream. And the patient is just flailing, trying to get out of the water stream, screaming, it's hot, it's hot, it's hot. And the CNA is yelling at her, no, it's not. It's fine. Quit fighting. I don't yell at people in public. I don't. I will always correct you in private. I will praise you in public. I will correct you in private. But this particular situation, I used words that I am not proud of. And I got the CNA out of the room. I finished the patient's shower, got them back into their room. And when I got a hold of that CNA, let me tell you, it was not pretty, because you are running over somebody else's rights. And you have absolutely no idea the effect that that had on that patient's ability to trust anybody in that facility again. Don't do that. Right? If the patient tells you it's too hot, it's their body. Believe them.
That actually happened to my grandfather.
Oh my
But it was too
gosh.
cold. But they thought because he had dementia and Alzheimer's that he didn't know what he was talking about. He told them it was too cold, but they didn't believe him. And he was trying to get out of the shower.
That's crazy.
I would have a few words about that.
I did, believe me, my dad had some words to say.
Absolutely. Help is not help if it doesn't help. Right? So please remember that you are physiologically different than your patients. So we can't approach this with patients the same way we approach it with ourselves. Okay. So that layer of fat helps keep outside temperatures out, but it also helps keep body temperature in. And you're going to see this with a lot of your patients. They're going to want the environment a little warmer than you're probably going to be comfortable with, especially those of you who go into home care. Keep that in mind. Those houses can get really hot. And trying to make it comfortable for you is going to make it uncomfortable for them. So we kind of have to try to find a way to work around this. We also want to watch that water and make sure we change it if it gets cold. or if it gets soapy. And some of these skills are pretty long. Like partial bed bath, they give you 19 minutes to do. That water, it's only warm, right? It's not hot, it's only warm. So it's going to cool down pretty quick because room temperature always wins. Anybody ever go swimming at the park, the springs?
Mhm.
Yeah. What's the water temperature?
Cold.
72.
Yeah, it's 72, and that is
Cold.
cold. Yeah, when you jump in there, it's like, oh, that is cold. Yeah, that's 72, which is kind of what we, say room temperature is, So that water is going to feel cold pretty quick. Keep your eyes on that. If the water gets cold or soapy, change it out. Okay. Comfort. We're all about comfort. So the order here matters. Whatever we wash, we rinse. Whatever we rinse, we dry. Make sure you're paying attention to all of those steps. So what we're going to do, instead of putting soap in the basin, we're going to get that washcloth. We're going to wring it out really, really well. No drippy wet washcloths. Wring it out really, really well. And then we're going to put soap on the washcloth. And we'll use the washcloth to wash the patient, and we'll use another washcloth to rinse the patient. Hello? Good morning. Are you looking for information?
Yes, Patricia.
If you can go right next door, they'll be happy to help you.
Okay, thank you.
Thank you. All right. So we're going to put soap on the washcloth, not in the basin. Think about what soap is like on the skin. This is like a microscopic view of soap particles that's left on the skin. It'll actually dry the skin out. It can cause it to crack. And now we've got more doorways in for those pathogens. So we want to make sure that we're rinsing well. Don't get the surface wet. This is why we have a barrier, but it's also why we want to wring out those washcloths really, really well. We don't want drippy wet washcloths. If the sheets get wet for the test, you have to address it. You don't actually have to change them, but you have to say the sheets are wet. I would change it. Don't leave your patient laying in a wet bed.
You're not gonna have to give a bed bath as a skill, are we?
Yes.
I was just
No. That is a mannequin skill. It's one of 4 mannequin skills. Yeah. Yes.
Red flag.
Bed bath is a tested skill. We'll get there a little later in the program, but it is a mannequin skill. But again, you don't want those sheets wet. Even though it's a mannequin, we're still treating it like it's a real person. So if the sheets get wet, we have to say, I would change the sheets. But you can avoid that by just putting a towel on the sheets to keep it dry.
How do you go about like soaping the patient and then rinsing?
I'm going to show you that. We're going to start with hand and nail care, and then we'll do foot care. We're working our way up to partial bed bath. Okay. All right. And then if we're going to put lotion on, we always warm the lotion first in our hands before we apply it. Don't put cold lotion on somebody. It's not comfortable. So warm it up in your hands and then apply it. But anytime we put lotion on, lotion is only going to absorb, your skin only absorbs so much. Whatever's left lays on the surface of the skin. And especially with hand care, it's going to make your hands slippery. That's a safety issue. Things can fall, slip out of their hands like hot coffee. So when we're working with lotion, we always warm it up first and then wipe off the excess. Now, there's one principle here we're not going to cover. We will get to that a little bit later in the program, just like we missed 2 on linen rules that we're going to get to. We're going to get to this a little bit later in the program, but everything else for washing rules we should know. Now, basin cleaning. I'm going to make this super easy for you. You guys are going to want to complicate basin cleaning. Don't. Anything we use for the patient, we simply rinse, dry, and store. That's it. Rinse it out, dry it off, put it away. These are single patient use items. So that basin is not getting shared between patients. It only goes for that one patient. So rinse it out, dry it off, store it. But there are situations where we will need to disinfect it. There are some situations that require us to disinfect. Your care plan and your facility policy will dictate for you. The process that we're going to use allows for disinfection to happen. It's the same process both ways. Rinse it, dry it, store it, or disinfect it. The process allows for either one. You're going to see this in this skill. You're going to see it again in multiple other skills that we do. Don't get all tied up in this right now. I just want you to watch it first, and we'll talk about it a little more as we go. Okay. What I want you to remember here is we're going to rinse it, we're going to dry it, and we're going to put it away. If we have to disinfect it, there's a step there that allows us to disinfect. Okay. So we're going to go through these slides really quickly. I have a whole lesson on this on page 91. When we're dumping a basin, we dump it where it normally goes. If it's urine or feces, where does it normally go? Toilet. Anything else goes in the sink. We simply rinse it. We don't have to wash it out with soap or anything. We're going to rinse it. We're going to dump the rinse water wherever we dump the substance. If it was urine, when we rinse the bedpan, we're going to dump the rinse water in the toilet. If it's mouth care, we dump the saliva in the sink. We're going to rinse it and put the rinse water in the sink. So you dump it wherever it normally goes. But if we have to disinfect after we rinse, we're going to set that basin down in the sink. If we have to disinfect, this is when we would disinfect. But you can't hold a basin with dirty gloves while you're disinfecting. So that's why we have to put it down in the sink. Once we've disinfected it, we can't pick it up with dirty gloves, so we're going to use a paper towel. So the process is going to be the same, whether we're disinfecting or not. We're going to dump it, rinse it, dump it, set it down. Use a paper towel to pick it up. Use a paper towel to dry the inside. Use a paper towel to dry the outside. And then grab one more to open the drawer with. Remember, we talked about that early this morning. So you're going to see basin cleaning over and over and over and over and over again. Let's see here. Let's see if I can go back here.
Question.
Yes.
When in a hospital setting and the patient is discharged, I've seen it both ways. I've seen some people like pack up the basin, all of the bath products and everything that was used and send it home with the patient.
Absolutely. They paid for it. Yep. They paid for it. They can take it. A lot of people won't take it home because they don't want the reminder, but yes, they absolutely can and probably should. Yeah. They make great cleaning buckets. Sure. Absolutely. Absolutely. You paid for it. Take it. All right. So if you look here, you can see all of the skills that basin cleaning is going to be part of. So we're going to see this 1, 2, 3, 4, 5, 6, 7, 8, 9 times. Okay. Don't get too wrapped up in it today. We're going to see this over and over again. Okay. Let me get to where I'm supposed to be here. The paper towels away. All right, so you're going to see basin cleaning in a lot of skills. Don't worry if you don't get all the steps right away. Everything is cleaned the same way. We're going to see this over and over and over again. But the biggest thing I want you to remember here, super simplified, we're going to rinse it, we're going to dry it, we're going to store it. Rinse it, dry it, store it. Okay. Any questions on that? All right, let's talk about hand and nail care now. So if you, Anthea, when ambulatory a patient, how many steps do you do? I'm going to ask you guys, how many steps would you take? You've never seen this skill. You've never seen anything about this. How would you know how many steps to take? Say it loud.
Care plan.
Care plan. There's your answer, Anthea. Follow the care plan. Okay. So when we're doing hand and nail care, we're going to soak the hand in water. We're going to take it out and wash it. We're going to put it back in the water to rinse it. We're going to take it out and dry it. We'll clean under the nails with an orange stick. We'll file the nails with an emery board, and then we're going to apply lotion last. If we use lotion, we warm it up first and wipe off the excess with a towel.
This is for long-term care facility patients,
Right.
right? Not hospital.
Yeah, you're probably not going to do this in a hospital. This is for maintenance. And we're going to get into a little bit more about why we do this when I talk about diabetes. And I think it's Wednesday. We're going to talk about diabetes. Let's see here. Yes, Wednesday. So we'll talk a little bit more about this on Wednesday. But the whole purpose of this, guys, is to keep nails short and smooth. If you file nails on a regular basis, like once a week, you never have to clip them. And nail clippers are not allowed to be used by CNAs. Nail clippers are not allowed to be used by CNAs. So if you file nails once a week or on the regular, you never have to clip them because we're keeping them short rather than letting them grow and then clipping them off. Make sense? That's why we're doing hand and nail care, is to get those hands clean, because chances are if this patient is having hand and nail care done, they're not going to the sink and actually washing their hands. So this is going to help keep those hands clean and keep those nails in a manageable way. When we are filing nails, we only file in one direction, toward the center. Now, some of you guys probably do something like this, right? In fact, I have a nail that needs to be filed. So if I have an emery board and I have a nail that needs to be filed, normally I would take my emery board and go really fast across the edge of the nail, back and forth to file that nail, right? Right? Okay, the problem is that as we age, our nails become much more brittle. And when you go back and forth across the edge of the nail, you're actually pushing and pulling that nail as you're doing that. And that can cause the nail to split right up the middle and fall off. And it is horribly painful when that happens. So we don't want to do that to our patients. We want to file in one direction only, so toward the center. See the difference? Toward the center. And then just go across that tip to make sure it's not pointy. When we clean under the nails with an orange stick, this is an orange stick, has two ends. It has a pointy end and a slanted end. We're going to use the slanted end. It's kind of like a scoop. Just put it under the edge of the nail, circle it around to get any debris that's under the nail, and then wipe it off on the towel before you go to the next nail, because we don't want to import stuff from one nail to another. Okay, good. Questions? No? I'm going to show you the video on this one. It has really good close-ups to show you exactly what to do. And then we'll go on break. Oops, hold on, guys.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place a barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
please.
okay?
That's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. You're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good.
That is that I'm cleaning the
We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Right. Any questions on that?
Did you wash your hands when you brought the basin to the sink? Or you
No.
just dumped it?
Just clean the basin, put it away, and then you're going to wash your hands at the end of the spill.
The purpose of doing the hand and nail care is not to actually like wash and disinfect the patient's hands.
It's to wash the hand, yes, but it's more to keep the nails at a manageable length and to keep them clean.
Okay. So because when we wash our hands, it's supposed to be for 20 seconds, and you're supposed to be able to create bubble with the soap.
Right. We're not. That's not for the patient.
Okay.
Yeah, that's not for the patient. So I'm going to put a comment up here on the screen, and I want you guys to answer this question. Okay. When doing respiration, how much do you count for? How long do you have to count for respirations?
What the care
What
plan
the
says.
care plan says.
Say it loud.
What the care plan says.
Care plan. Very good. Very good. So even though you, Caitlin's, thanks, Caitlin. She's reloading the rest of the videos. Even though you don't know that skill, right? We haven't gone over respirations yet. You do not know that skill, but you were able to answer that question. Look how far you come in a week. And I'm not done with you yet. Right? So you guys have way more knowledge about the test than most people that are testing already. And we're not even halfway done. Good? Questions? Okay, we're going to go ahead and take our break. Come back at, I don't know, whatever 15 minutes. Don't go by that clock. Whatever 15 minutes is.
Patricia, I took my test. I don't know if you want me to tell you now what I got.
Hold on 1 second.
Yeah.
Okay, what was that?
I took my tests. I missed 3 on
Oh.
chapter 2, and I didn't miss any on chapter 3.
Very good.
Okay, thank you.
Thank you.
Why does the clock keep going out of whack?
I think the battery is going dead, so I'm going to change the battery out. There we go. Now you can use the stuff. Okay, I'll be back in a minute.
She'll be able to make a difference because you just saw how it was for him. She's good. Love it. They said it was just good. I'm glad that you're just well, yeah. That's the good thing, that coupon she gave us yesterday, is that only for uniforms? I think so. I just hoping if we could use them in the house. Yeah. Because the hair covers on that stethoscope hurt my ears. So I noticed she sells hair covers, but it was like $30. Just hair covers. So I thought, well, I was gonna ask her if it's just only uniforms.
But does it sell accessories or just uniforms?
Oh, you can get your camera. I have to ask her. I'm just gonna slip the hangers in. I'm gonna have some hangers.
Just a moment.
Any questions? Any questions? No? All right. We are going to move on now into changing an occupied bed. This is going to be on page 141. All right, so the principles involved here are skill rules. So we're going to follow the care plan. We're going to do our opening, evaluate if we need gloves. We'll use a barrier for our supplies. We're going to use a privacy blanket because our patient's going to be uncovered. Linen rules are going to apply. We're going to have to learn something new here, scoot and roll. We have to learn skill-specific steps, and of course, the closing will always apply. So these are the two steps that we didn't get to on linen rules. So we're going to finish up linen rules here. And the two steps are clean rolls toward you, dirty rolls away. And don't let any linens touch the floor, whether it's clean or dirty. So let me explain to you clean rolls toward you, dirty rolls away. When we're changing an occupied bed, that means the patient is still in the bed. So that means the patient is still in the bed. Now, because the patient is still in the bed, you don't have to worry about the dirty sheet touching the clean sheet because the patient who touched both of them is still in the bed. Okay, so this isn't a sterile situation at all. We're just trying to get the dirtier sheet out from under them. Does that make sense? Okay. So when you do it this way, clean rolls toward me, dirty rolls away. So if I have a sheet on the bed that the patient is laying on, okay, and I want to put a clean sheet on that bed, I'm going to turn the patient onto their sides. They're taking up less space, right, because our sides are a little skinnier. So I'm going to turn them on their side, and then I'm going to roll the dirty sheet away from me, tuck it up underneath that patient. I'm going to take the clean sheet and roll it toward me and tuck it under the dirty. Now, when I do that, the only part of the sheets that are touching are the undersides of the sheets. But it really doesn't matter because the patient is touching both. Okay. A lot of students try to make this into like something sterile. Well, the pillow is still on the bed. Yes, so is the patient. Okay. You're not trying to do sterile here. We're just trying to change the sheet without getting the patient out of bed. But I will tell you, if you can get the patient out of bed, do so. Way easier to change a bed with nobody in it. If I walk by an empty bed, my very first thought always is, do those sheets need to be changed? Because I can change a bed with nobody in it in 2 minutes. To change a bed with somebody in it is like 9. So I'd much rather change the bed if nobody is in it. Does that make sense? Okay. So if the patient's out of bed in the shower room, if they're out of bed at a test, if they're out of bed for whatever, change the sheets then. But we have to learn how to change sheets with somebody in the bed because there's going to be situations where we don't have an option. We're going to talk about bed rails in a minute. And the answer to that is no. Yep. Just hold up. We'll get there. Okay. So does everybody understand the concept here? We're going to change the sheets, the bottom sheet, a half at a time. Clean rolls toward me, dirty rolls away. Okay. And then our other rule that we haven't covered is don't let any linens touch the floor. Doesn't matter whether they're clean or dirty. The floor is not clean, but we don't want to make it any dirtier. Well, that's a problem for us though, because at home, you probably do what I do. When I take the sheets off my bed, I take them off the bed, roll them up, and throw them on the floor until I'm done. And then I pick them up and take them to the laundry room to wash them, right? That's what most of us do. We can't do that in a clinical setting. You cannot dispose of dirty linens onto the floor. You can't let anything touch the floor. So what are we going to do with them? So no linens touch the floor ever. Not clean, not dirty. They have to go directly into something to hold them. So either in a laundry basket or linen hamper, into a soiled utility bag, or at the very least, put a barrier on the floor and put the sheets on the barrier, but never directly on the floor. Now, those soiled linen bags, you guys know about Tide Pods, right? Yeah. Okay, those soiled linen bags were the original Tide Pods. We've had this technology for decades. These bags are usually a really light blue color, and they'll actually be stamped soiled linens. Well, when you put the linens into the bag, that whole bag goes into the washing machine. It dissolves and becomes the soap, just like Tide Pods. And the problem with that is anything that goes into that bag is going into the washing machine. So when we're taking sheets off the bed, we need to be watching for things like hearing aids, dentures, cell phones, things that really should not go through the washer and dryer, because nobody is taking those sheets and shaking them out and making sure there's no foreign objects in there. That's your job. Does that make sense?
The whole bag into the washer.
Whole bag into the washer.
Okay.
Yep, whole bag into the washer. And I do the same thing here with these mesh bags. That whole bag goes into the washer and the dryer.
The mesh bag doesn't dissolve though, right?
No, they don't dissolve. But yeah, we've had that technology for a very long time. And I remember way back in the 90s when I became a nurse. It was actually 90 was when I became a nurse. Back then, I thought, wow, this is amazing. If I could get this at home, that'd make laundry a whole lot easier, right? Just throw the whole thing in the washer. I don't have to sort it. Don't have to do anything. Well, eventually they did come out with that technology for us, and we call them, pods. So it's very interesting to see how these infection control strategies are utilized.
The
Okay.
military does that, and you're in a ship for that.
Sure.
That's how they do it. They throw bags of stuff into that.
Absolutely.
Yeah.
Absolutely. Is everybody good with this? Okay. Most places are going to have a special room for soiled items. Remember I said last week that we don't keep dirty items in the patient's room in most cases? So in the hallway, you may have a linen cart like this or a linen hamper like this in the hallway. But a lot of times they're going to be kept in a special room called soiled utility. And that's what this room is all about. This room is all about holding things that are soiled. So nothing clean should ever go into this room. If you're gathering supplies, don't go in and get your towels and washcloths and then go into soiled utility with those items. Okay? Nothing clean ever goes into soiled utility. Nothing dirty ever goes into clean utility. You have to keep those two separate. But usually if you're putting the items in a bag and we don't have a hamper or a soiled linen cart available, you'll just take everything and put them right into this room. Again, this is going to fall under your facility policy. How do they want this handled? Every facility is going to be a little different. If you're in a hospital, then they have linen carts in the hallway, or linen, soiled linen in the hallway. So just put it in there. If you're in a long-term care setting, they're probably going to have you put it in a special room, and then somebody would go in and get all of that and take it to laundry. Every facility is going to handle this a little bit differently. The big thing I want you to remember is that nothing goes directly on the floor. Okay? Good? Don't store items for later use. We've talked about this. Once they're out of your sight, they can't be considered clean. So anything that's left in the room is not clean. We have to discard it. Now let's get to your question. We're going to talk about a new principle called scoot and roll. And this is how we're going to keep our patients safe as we do this skill. Side rails are a restraint. Let me say that again. Side rails are a restraint. They are specifically designed to keep a patient confined in bed. Side rails are a restraint, which means that we cannot use them without a doctor's order. Yeah, that's going to challenge some of the things that you know about side rails.
Did that change or is that always been a policy?
No, it changed in the 90s.
Oh.
But yes, side rails are considered a restraint, and side rails do not do what you think they're going to do. And let me explain. This is one of those what we call false cognitives. We think we know something, but what we know just ain't so. Okay, and I'm going to explain this about side rails because again, most of my time with you is breaking down things that you think you know and then building it back the way it should be.
Are there exceptions for bedbound? Like my client this weekend was bedbound. She could not move or roll. It was just me doing her backside. I can't be on that side monitoring her from rolling over because she has no mobility.
Right. Well, we're going to talk about how to do it in a minute. But the principle here that side rails are a restraint and require a doctor's order, there are no exceptions to that. So let me explain to you how to do it without the use of side rails. Okay. And we used to years ago be able to say, well, the patient asked for side rails. The problem is that a lot of people misuse that and would say, but it wasn't really true. So we have to be really, really careful with the use of side rails. But let me explain why this came into being. Okay. And we talked a little bit about this last week, actually. Remember that when you lay around for a significant period of time, you get weaker, right? Remember we talked about that? Okay, you get weaker. Well, if we put a patient into bed and put the side rails up to keep them in bed, have we done anything to improve their situation? No, in fact, we've done just the opposite. We're actually actively making them weaker. And you can take an older person and make them completely bedbound for the rest of their life within 5 days. That is a tremendous amount of power. Think about that. That is a tremendous amount of power. If you put an older person in a bed and you confine them there for 5 days, that is all it takes to reduce mobility in many older people. And you can affect the quality of life for that person for the rest of their life because they'll never regain it. That's pretty significant. So this is why we cannot leave this in the hands of just anybody, right? That is a tremendous amount of power. And that's why we have to have maybe some safeguards in place. Because you may be thinking to yourself, well, I don't want her up and walking. She's a fall risk. And we use side rails in the name of safety all the time. But the problem is that when we stop and think about it, it actually doesn't do anything to improve safety. Staying with that person and walking with them to the bathroom, much more effective for safety. Make sense? Mm-hmm. Enabling them to continue to operate at their level of ability safely is much, much better than just restricting their mobility outright. So this is why in most hospitals, We don't even have side rails on the bed. They don't even exist. Instead, we hire sitters. And this is something you can all apply for right now. The technical term is patient safety attendant. You'll see it on all of our hospitals' jobs boards. Patient safety attendant. The informal name is a sitter. So you would be paid to come sit at the bedside and get staff when you don't perform any care, but you basically try to help the patient stay where they're at without the use of side rails and alert the staff when interventions are necessary. Okay, so patient safety attendant, you don't have to have any experience, no training, no nothing. All of you are eligible for that position, and it gets you into the hospital, which is where a lot of you want to work. So then you let them know, hey, I'm taking the CNA class. I should be testing, once you get your test date, and then you have an opportunity to promote from within. Okay, good? Yes.
So you have a patient that like just doesn't listen. Just doesn't want to stay in bed when you're not there, like just wants to get up, doesn't want to burden you by calling you to go to the bathroom, and they get up on their own.
Right.
And they are a fall risk. Is that
Right.
something that you would tell the nurse, and then the nurse would have to talk to the doctor, and the doctor would give the order then to use the rails?
We actually would not get a rail order for that.
So how do you protect?
Okay, but let me explain why. Because you're thinking about the patient as a completely different type of entity than you. So what time do you go to bed at night?
It varies. Most of the time 11 o'clock.
Okay, but you get to decide, right?
Yeah.
Okay, so what if I came to your house tonight at 7 o'clock and said, nope, you're done, go to bed. And then if you didn't go to bed, I tied you to the bed. Right? We think that's utterly ridiculous. You wouldn't do that, right? You would think I'm some sort of weirdo for doing that. What is the difference between you and that patient?
They're safe.
No,
They're fall risk.
you're a fall risk.
But I'm okay though. Like
Have you
can take
ever
care of
fallen?
myself.
Have you ever fallen?
I'm sure.
Okay, so you are a fall risk. Everybody is a fall risk. We can't fall back on that. Everybody is a fall risk. If you are upright, you are a fall risk. You can trip over your shoelaces.
This is so much more than a black and gray topic.
It's not black and white. It's very gray. But that's why I have to lead you there. Okay, so just kind of stay with me, and I'm gonna lead you there. So here's the problem, because a lot of people think in that direction, right? I want to keep them safe, and your motivations are all pure, right? You want to keep the patient safe, but the problem is by doing that, you are trampling over their rights. You just said, in the way you said it was absolutely perfect. What if they refuse to stay in bed?
There's nothing you can do for that.
Right, because they have the right to make decisions for themselves, right?
I just feel like as their caregiver in that time period, I feel like there should be something better I can do to protect them from hurting themselves.
Okay.
Like that, to me, in my mind, that makes them a harm to themselves.
So we need to pay better attention to safety rather than restricting the patient.
What do you use in time like that to help keep them safe?
But again, you're thinking about restrictions, right? So let's go through this scenario. Okay, let's say we have a patient who's in bed and we don't have side rails because we don't have a side rail order. So, and the patient, and I'm going to use that same term, refuses to stay in bed. Well, they have every right to be up, just like you do. Just like you do. If I want to get up at 3 o'clock in the morning and go sit on my couch because I can't sleep, I have every right to do so. Even though I've got a bad knee and I probably could fall because I got a puppy running around on the floor, right? There's a lot of unsafe situations there. But nobody can force me to stay in my bed if I don't want to. So what are some things that we could do to make it safer for me to get up? Well, I don't know, maybe having making sure that there are no rugs and blankets on the floor that I could trip over. Maybe having a light, a motion sense light that comes on so I can see the floor if I get up out of bed. Maybe making sure my puppy is in a secure location, not running around that I could trip on. Maybe making sure my shoes fit appropriately while I'm up walking and I'm not just putting, those little slipper slide things on. Maybe moving the couch a little closer to me. Maybe my husband getting up with me and making sure I get to the couch and going back to bed, right? So there's a lot of things that we can do there other than just saying, stay in bed, right? So that's where we have to get the nurses involved, because the nurses are there to figure out all real problems and all potential problems. So if we've got a patient who doesn't want to stay in bed, that's their right to not stay in bed. It's their absolute right. We have to be careful not to treat adults like children. They're not children. Once you are old enough to self-determine, you don't want anybody telling you what you can and cannot do. And that does not stop when you get older or when things get unsafe. So a lot of people will call this the right to fall, and that's absolutely not correct. Okay. We're not, they don't have the right to fall, but they do have the right to self-determination. It's up to us to make sure that they're safe while exercising that right.
So say they do get up and they fall and they hurt themselves in a minor or severe way. Does that fall on them or does that fall on the CNA or the nurse? Like who's responsible for that action?
Okay, so the question is, was a care plan put in place and followed?
Okay. So
Okay.
long as you did everything right.
It's
and they
not
didn't
on you.
Hurt themselves.
Right.
Based on their own actions. It's on them.
Right. But our goal is that that doesn't happen and to keep the situation as safe as we can.
Could you also get like a walker or a cane bedside to help them?
Again, care plan. That's not something that a CNA can, remember, CNAs can't change or add to or subtract from. So if you've got a situation, let's say that you're in home care. Okay, let's make this even more complex. Okay. So let's say we're in home care. We've got a patient. You're there alone with the patient. The patient is weak, maybe has been in bed for 5 days, very weak, and you are concerned about the patient's ability to walk by themselves, that they're a fall risk. Now, CNAs can't decide that a walker is appropriate. Not our job. But we can let our supervisor know, hey, I've got some concerns here. This patient is very weak, unsteady on their feet. There is no order for a walker. Can we get a physical therapy consult to come out here and put a plan in place? Can a nurse come out here and visit and develop the care plan? We need to know what we can do to make this patient comfortable, safe, but also not trample on their rights. Because this is why. Let me show you the next slide and it'll help you kind of understand this, okay? You don't need side rails to keep your patient safe. In fact, side rails cause a significant number of injuries. Side rails kill about 600 people a year. Because when you put side rails up, these are real numbers, guys. When you put side rails up, you've now produced an obstacle for the patient to get over or around or under or through. And when you produce an obstacle, your unsafe patient is now exponentially more unsafe, because that side rail is not going to keep them in bed if they're determined to get out. Now, you can tell me all day long at 3 o'clock in the morning when I want to get out of bed because I can't sleep, that I cannot get out of bed because I've got a bad knee and I'm at risk of falling. You can tell me that all you want, but if I'm uncomfortable in the bed, what am I going to do? I'm going to get up. You put a side rail there, I'm going to go around it or over it or whatever I have to do, because if I'm determined to get up, I'm going to get up. I am an adult, and no other adult on this planet has the right, including my own husband, by the way. He wouldn't even dream of trying to tell me what to do or what not to do, because I am an adult and I have the right to make decisions for myself. Now, he can tell me, hey, I'm concerned, right? But he is not about to put a side rail up on that bed and try to keep me in that bed, because try it.
Right now.
Yeah, try it. No, he knows. So we have to understand, right? Our patients have rights. Our patients have rights. And this happens way sooner than you think it does, by the way.
Does it take a doctor's order to ask for a person to sit by them? That has to be a doctor's
Yeah, that's a
order.
doctor's order too. Yeah, so we're going to come back to this in a second, but let me show you why. Let me go to, there's a specific one I need to, where is it? I don't have it. All right. So let me explain why. Angel asks, are bed alarms considered a restraint? No, bed alarms are a restraint alternative. Now, what a bed alarm is it's a pad that goes on the bed that when pressure, okay? So when pressure is on that pad, it's quiet. When pressure comes off of the pad, so when the patient gets up, an alarm sounds. So now we know that the patient is up and moving. Somebody should probably go in there and help out, right? So these are restraint alternatives. We're not keeping the patient in bed, but we're notifying us when they're out of bed. It's a much better option. Yeah, everything needs a doctor's order. Yes. Yes. Yep. Yeah. Well, but the nurse will call and get the order. Yeah.
That still takes forever.
Oh, sure it does. Absolutely. It does. But here's the thing. And I know I've got a slide on this, but I think I go through it on Wednesday. But let me kind of lead you through this. Okay. Everybody knows babies, right? When a baby comes home from the hospital, you put the baby in a crib, and the crib is designed to keep the baby safe, right? Right. Baby's not going to stay, and we don't want them rolling off. I mean, this happened last night. My little puppy, my husband put the puppy on the couch, and I'm like, overprotective mom, I'm like hovering, don't let the puppy fall. Don't let the puppy fall. And what did the puppy do? Fell right off the couch, right? Onto the floor. And I'm like, oh, fell on his head. Is he okay? I'm protective mom, right? But, puppies are puppies. They move around. Babies are babies. They move around. Adults are adults. And you know what we do? We move around. You do it in bed all the time. You don't need side rails to keep you in bed, though. You move all night long. You don't need side rails to keep you in bed. So let me explain to you what happens. Okay, so if we have to have side rails in a crib when we're babies, but we come to a point where we don't have side rails and as an adult, something changed. What changed? Well, when we're about a year and a half old, roughly, some a little earlier, some a little later, you know what we start doing in that crib? We don't stay. We climb out. And now, that baby falling from a bed is one thing. That baby climbing the rail and falling from a further distance, did that really keep him safe? So what do? When babies start climbing out of a crib, what do? Toddler bed. And toddler bed is low to the ground. Yeah, why? Right, they're not falling a great distance. That's right. So when that crib was in place and the baby climbed to the top and fell, the possibility of injury was much greater. Does that make sense? All right. The only difference between a crib and a side rail is what we call it. Okay. So when you have a baby that's not safe in a crib at a year and a half old, right? We put them in a toddler bed. They learn how to sleep in a bed because they develop something called spatial awareness. And this happens somewhere between a year and a half and 2 years old. Somewhere in this time frame, we learn to sleep in a bed. And that's because a small part of your brain is always on. Doesn't matter whether you're sleeping or not. This is why you can sleep at night, toss and turn in bed, and still stay in the bed, because that little part of your brain is always aware of where you are in the space that you have. You can also nap on the couch and not fall off, even though the couch is smaller. You can go to a friend's house and sleep in an unfamiliar bed and not fall out, because this part of your brain is always on, except with alcohol and some medications. This is why you fall off a bar stool when you've had too much to drink, because it puts that little part of the brain to sleep. But outside of alcohol and some medications, we are fully capable of keeping ourselves safe in the middle of the bed, as long as we're competent. Make sense?
So that works the same for elderly.
Right. So putting side rails up, all you're doing is causing them to fall further. This is why side rails, we have to think about side rails a little bit differently, right? We think about them to keep our patients safe and confined, but what we've actually done is created an obstacle for them to get over, and that can cause injury. So you have to think of the bed like this. The middle of the bed is a safe space. The edges of the bed are not safe. Does that make sense? Edges of the bed are unsafe zones. So we should never have a patient in an unsafe zone. So in order to illustrate that, since you brought it up, I'm going to ask you to come up. Can you come lay in this bed for me? Lay on your back. Keep your shoes on, get comfy. Yeah, it's a comfy bed. All right. So I asked her to lay in bed on her back. Did I ask her to lay in the middle of the bed?
No.
Now, she knows she's not here for very long. I'm just demonstrating something really quick. Where did she put herself?
In the middle.
Did I ask her to do that?
No.
Why did she put herself in the... It would have made more sense for her to lay on the edge, because she knows she's going to get right back up. Why did she put herself in the middle of the bed without me asking? Okay, implicit memory. Absolutely, because her brain knows that this is the safe space for her. Does that make sense? Okay, doesn't matter how old you are, from about 2 years old on, you will do this automatically without thinking. You won't even be aware of it. But it goes beyond this, okay? So to illustrate this next part, can I get you to roll onto your side and face that window for me? Just what did I ask her to do?
Roll on her side.
Roll on her side. Did she roll?
No, she positioned herself in the middle on her side.
If she rolled, where would she be?
On the edge.
Yeah, on the edge or maybe on the floor. Yeah, absolutely. But she didn't do what I asked her to do. I asked her to roll on her side. Her brain knew that that was not safe. So what did her brain do instead? Yeah, so she's still on her side, but where is she in the bed? Yeah, in the safe zone, guys. Did I ask her to do that? In fact, she went over what I asked her to do. She didn't do what I asked her to do. Right? And you did a good job. Yeah. But we do this automatically without, thank you, without anybody having to tell us, right? Our brains will always keep us in the middle of the bed. It's automatic. And it doesn't matter what bed you're in. Doesn't matter whether it's a small bed, big bed, you will stay in the space that is safe. You're not going to be on the edge. So if we are going to turn a patient, after the turn, where do they need to be? In the middle of the bed. So I don't need side rails for that to happen. In fact, if I put the side rails up and just turn them, they're going to be in the unsafe zone. So even though that side rail is there, are they going to be comfortable with that? No, because their brain knows that that is unsafe. Does that make sense? Relying on side rails to keep a patient safe when you're turning them is actually counterproductive, because it's going to heighten their anxiety. So instead, what we want to do is scoot their whole body toward us. So they're laying on their back close to us, and then we turn them away from us. So that after the turn, where are they? In the middle of the bed. And we don't need side rails to do that.
Well, patients with dementia or Alzheimer's, do they still have that part of their brain working at those?
Depends on everybody's an individual. Depends, right? Depends. But yes, so memories that are made early in life, really early in life, and this is like one of the first memories we make, right? Early memories stick the longest because they're made with the best factory.
When the rails will be up when you're transporting the patient in the bed.
Okay. So if the bed is in motion, we have to have the rails up. So it's kind of like keep your arms and hands inside the arms and legs inside the moving vehicle at all times, you know, that type of thing. So yes, side rails will be up when the bed is in motion. But I'm going to tell you, in most settings now, we don't take these beds anywhere. They're too heavy. They don't maneuver very well. So we will put the patient on a stretcher and take them where they need to go with the rails up on the stretcher. But in most settings, you're not even going to have side rails on these beds because we can't trust that you understand this and that you won't use them. Because a lot of people use side rails with great intentions. They think they're doing the right thing. But by using side rails, you're actually putting the patient at more risk because now you're putting them close to the edge. What if that side rail fails? There's nothing there to keep the patient. Does that make sense?
Yeah. That kind of
Does that help you?
Why the new beds are made differently.
No? Yeah, the new beds, you won't see side rails.
I know the ones that actually do have them, their controllers are on the outside of the railing and not in the inside.
Right. So what?
It's different for what CNA is normally going to do. They're not going to be doing what I was doing over the weekend
Okay.
a home health aide. She was quadriplegic. She could not move anything. She could not assist with anything. But she was 270 pounds. The care plan said to roll her onto her side to do the bed bath for the back. There's one of me. I can't be on that side to keep her safe from rolling, and this side to do the cleaning. It's just not possible. And that was what caused me to hurt my shoulder, trying to do both.
Okay.
Whereas if she would have just had a bed rail, I could have just put pillows there, rolled her on her side. She would have been safe, comfortable. I would have been able to do my job without getting injured.
Yeah. So in that case, she really should have been scooped towards you and then rolled.
I cannot lift I tried to scoop
Yeah.
on her sheet, 270 pounds. And I did call my supervisor and told him they needed to get someone out there to reevaluate our care plan. And they plan to, but the injuries already happened. There's nothing that can be done.
Yeah. And again, side rails may be indicated, but that has to be a doctor's order.
Okay.
Has to be a doctor's order. And it's specifically because the risk of injury is significant. I mean, 600 people a year die from side rails. That's not an insignificant number, right? So this is not a side rail, though. I do need to kind of point this out. This is not a side rail. This is a positioning rail. It has handholds. It doesn't affect the patient's ability to get out. Okay. This helps the patient position themselves in bed. This is a positioning rail. When we put this one up, this becomes a side rail because it eliminates the patient's ability to get out of bed safely. Most of the time, you will not even see these bottom rails on the beds in a clinical setting because if we have to get a side rail order, we're going to have maintenance come and put them on. They can't trust you. They simply can't trust you. Okay.
So those positioning ones, those you can put up.
These are
at any
fine.
time if the
These are
patient
fine.
wants it, or if you feel that the patient would benefit from it.
Yes. But again, CNAs really shouldn't be using judgment. So when you say when you feel, I have to be very careful there
Yeah.
because CNAs are not supposed to use judgment. Who should you go to? The nurse.
So if the patient asks for it, then it's okay to put it up.
Sure.
Without talking to the
You
nurse.
still have to let the nurse know.
Okay.
Everything you know, that nurse needs to know. Everything you know. So if the patient asks for positioning rail, top rails, who should know? The nurse. If the patient's eating more than normal, who should know? If the patient hasn't peed this shift, who should know? The nurse. Everything you know, the patient or the nurse should know. Yep. So does that kind of make sense? We've got to be really, really careful not to treat our adult patients like children. And this, like I said, is not insignificant. 600 people a year die from side rails. And that's primarily because we try to keep somebody in a place they don't want to be, and they're adults and they're not going to stand for it. I am the type of person that if you tell me to lay down in that bed and stay, I'm going to get up just because you told me to stay. Right? Who are you to tell me what to do? I worked very hard to become independent. And you don't have the right to take that from me. You don't have the right to take it from anybody else either. So we've got to be really careful. And we do it all in the name of love. We do. We have the best intentions in the world. But the problem is we're still running over their rights. Does that make sense? Now, I know I'm going over this a lot, but this is super, super important that you get this because you're going to have a couple questions on the state exam about it, about side rails. And the biggest thing that I can tell you is if an answer treats an adult like a child, it is always wrong. Okay? Does that make sense? Okay. So what I want you to think about is if it's not something that you can do to another stranger in Winn-Dixie, you can't do it in the hospital either. Okay.
I've also heard that there's a pretty decent statistic on the amount of deaths with cribs.
Sure, you got it. Yeah, you have to be careful. Absolutely.
And my cousin has a baby and she's about to have another one. She had just gotten a crib like where it lifts up the actual mattress and you can change the height of it. And they don't go as high as they used to.
Right.
Because of the safety issue.
Right.
So they've even started changing the crib.
Yeah. Yeah. Yeah, we do things with the best of intentions sometimes, but thinking it through from a different perspective may give us a little bit more clarity. We tend to get blinded by what we know that we don't take in what we don't know. Okay. So when you turn a patient, we always have to make sure after the turn that they're on their side in the middle of the bed. And we want to make sure that they're facing away from us. Now, the reason for that is weight distribution. Most of our weight is distributed along the back side of us when we're turned on our side. So gravity always tries to pull somebody onto their back. Always, 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 always. Well, if you've turned somebody towards you, that means that all of their weight is way across the bed on the other side. And if they start to roll onto their back, you don't have enough leverage to stop that. Or you may injure yourself by reaching all the way across the bed to try to stop it. So turning a patient towards you is not a good idea. It's bad body mechanics. But there's another reason it's bad. And there's no easy way to say this, guys, so I hope I don't trigger anybody. But you never, ever, ever turn a patient toward you because you never want them to be face level with your crotch. That can seriously trigger patients. If they're already vulnerable, guys, they are laying down. That is a vulnerable position. They're not dressed for company. They are vulnerable. They're relying on you to take care of their most intimate details. If you turn them so they're eye level with your crotch, that can present a issue. Okay? Does that make sense? Always remain behind the patient's behind. Turn that back this way. Okay, so we scoot the patient toward us. Now you can do this a million ways. You can scoot the patient in segments. If they're able to, you can ask them, scoot toward me. That's the easiest way. You can use that for the test because our patients are able-bodied people. Scoot toward me. You can use segments, move their legs, their hips, their torso, their head. You can use a draw sheet, which is a flat sheet folded in half under the patient. And we use it as a sling to lift our patient and move it toward us. And that's probably what I would have done in that situation is use a draw sheet.
Offered no training on that.
Yeah.
There was not. It was a 6-hour training course, and boom, you're out.
I know. And that's so sad because you really, especially in home care, you really should be trained on each individual patient before you assume the responsibilities.
There's not enough people to take you out individually.
I know. I know. And we're short staffed everywhere. And I get it. I do understand. But a draw sheet might have been a significant help there. You can also use something called a slide sheet. These are really cool. They're like super slippery material that you tuck under the patient and it almost levitates them. It's like super expensive material. I mean, one slide sheet's like $2,000. They're like crazy expensive. But they're really nice because it reduces friction, right? So you can slide a patient, even somebody that's significantly large, toward you with little effort. So that we've got a lot of opportunities there to scoot our patient toward us, and then we turn them on their side. And in an upcoming episode, we're going to show you how to position somebody to turn somebody that can't move on their own, to turn them easily. And you can turn somebody 3 times your body weight using this process with no stress on you or them. I used to take care of bariatric patients that were 600, 700, 800 pounds. And I used to do it all by myself and using these techniques. It's all about knowing the right technique to use, right? All right, so the patient is always turned away from you. Now, there's a couple of different things with bed position. Beds have 2 different ways of being positioned. So head of the bed is one, entire bed is another. Okay, they're not the same. Head of the bed is up for certain skills like mouth care. We would want the head of the bed up, right? But at the end of the skill, it's always patient preference. Doesn't matter. Up, down, whatever they want. Entire bed is when we raise the entire bed up to make it comfortable for us. But at the end of the skill, the entire bed must be in the low position. So do you guys understand the difference between those 2 adjustments? Head of the bed at the end of the skill is always patient preference. Entire bed at the end of the skill always has to be low. Okay? All right? So here's a couple things with making an occupied bed. First, we want to make sure the patient is never laying on the bare mattress. They have to always be on a sheet. So we're going to roll the old sheet toward the patient and tuck it under them, and then stretch the new sheet out, roll it toward us, and tuck it under the old. That way we don't turn the patient back onto their back onto the bare mattress. Patient should never be on the bare mattress. All right, so step-by-step instructions are going to be located on page 142. You can see all the supplies at the bottom of the page there. And yes, you do need to learn your supplies. Our care plan at the top of the page tells us to change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed, but cannot get out of bed. So we can ask him to scoot toward us. It says can roll and move as directed. So just ask them, scoot toward me, please. And then we're gonna ask them to roll on their side. Okay. It says that a draw sheet, underpad, and blanket are not required for this skill. So top sheet, bottom sheet, pillowcase. That's it. That's all we're changing here. Super easy. All right, so let me show you the video for this one. It's got good close-ups. We're not going to get to range of motion. So we'll have to work that in another day, but it's a 2-minute skill. It's way easy. We got time to work with later. It's okay. But after I'm going to show you this video, we're going to get into blood pressure. So I know that's like the big one. Okay. So let me show you this skill.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good. How are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. I'm going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll so that you're on your side facing in that direction? Thank you. I'll remove the 2 corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient, tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now.
Remember, the patient always needs to be covered.
We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done.
All right, any questions on that?
My question is that still does not include gloves. I get that part, but what about if while you're changing the sheet,
So our glove rules are always going to apply if we're going to touch body fluids, personal skin, or non-intact skin. We would need gloves. This patient for this video was fully clothed, holding onto all of his own body fluids, and there was no non-intact skin. So I didn't need gloves, and you won't for the test because your patient falls under all of those parameters. In a clinical setting, if I'm not 100% sure about what's under the patient, I'm going to wear gloves. Okay. All right. So Shay asked, does their bed sheets get changed every day? And the answer to that is it depends on your facility policy. Again, you're going to go by your facility policy. Usually in most facilities, it's every 3 days and as needed. You know, if the sheets are all sweaty or if there's body fluids on it or, you know, wound drainage or whatever. If the patient's out of bed, I'll probably go ahead and change your sheets because it's way easier. So if they're at a, you know, test or something like that, but you'll go by your facility policy. And then Angel asks, is it required to document what time it was changed? Again, you're going to go by your facility policy as to what's required for documentation. Okay. If you're in home care, you're probably going to check a box. If you're in long-term care, you're probably not going to document it at all because it's just part of daily, you know, daily care. If you're in a hospital, you may be documenting that the sheets were changed. Every situation is going to be a little bit different depending on the needs of that facility. Okay, good. All right. So let's move on. Let me make a note here. Okay, so let's move on to blood pressure. I'm going to find the right. Okay. All right, so blood pressure. This is going to be on page 56. The first thing that I want to explain to you about blood pressure, it is not tested on the state exam. You are not going to have to perform blood pressure for Prometric state exam. Other testing agencies do. There are some testing agencies that have you perform blood pressure with an automated cuff. Others require a manual reading. Prometric for Florida does neither. This is a non-tested skill. That doesn't mean that you don't need to know it. We need to understand what a blood pressure is and how to measure it. So let's talk a little bit about what a blood pressure is. All of these notes are on page 56 of your book. We saw this when we learned pulse. You've got a heart in the center of your chest. The heart squeezes, pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it, and so on. We've talked about this. We also talked about it for CPR as well. But if you look at this, you'll see that the wave of blood and the valley are two totally separate things. Here, there's going to be more pressure inside, and here there's less pressure. So let me give you an example that makes a little more sense. If you have a hose attached to a water faucet on your house, and you go out and you crank the faucet all the way on, water comes through the hose expands, gets bigger, gets harder, and there's more pressure inside. There's now water pressure inside. Turn the faucet off, and the hose kind of collapses a little bit. There's less pressure inside, right? So what your heart is doing is it's standing at the faucet going on, off, on, off, on, off. Now, if you were on the other end of the hose, when somebody's doing that, you'll see water, no water, water, no water, water, no water. When water is moving through, higher pressure. No water, lower pressure. Okay? Blood moving through, higher pressure. No blood, lower pressure. That is what we are measuring, is the amount of pressure inside this artery when a wave is moving through and the amount of pressure inside the artery in between the waves. That is what a blood pressure is. Now, normal for your top number or systolic number is 100 to 119. That's what we consider normal. This changed about 7 years ago, and it's now 100 to 119 for your top number, 60 to 79 for the bottom number. Those are considered normal.
Before it changed, did it used to be 120 over 80?
Okay, the problem with a single number is that it really has to be a range.
Like the highest number.
Yeah, 120 over 70 was what we considered benchmark or the standard, right? What we were trying for. But then they changed it to a range and they lowered it. So if you notice, what you were saying, 120 over 80 would actually be considered high.
That's why I asked.
Yeah. So 120 over 80, it would be considered high.
I was just in EMT school not too long ago. They told us 120 over 80. So.
Yeah, that's considered, according to the new standards, high. Yep. So when we're taking a blood pressure, this is a little complex. It takes eye, hand, and ear coordination. and you're not going to be good at it today. It takes about 45 blood pressures before you really start to dial this in. So we're going to go over the basics. I'm going to get you up to speed enough to be able to practice, but practice is really where you're going to dial all this in. Okay? This is when you really have to practice. There's no way around it. So we have a dial, a gauge. This technically is called a sphygmomanometer. That is its technical name. Most of us call it a gauge. It's way easier. And you'll see that the gauge goes up to over 300. Like all gauges go up to over 300. We are not interested in that. And I want to bring your attention back over here for a second. And that blue wall there. Can anybody tell me what that blue wall tells us? CNAs do normal. Normal. A blood pressure over 300 is not even close to normal. That is not an appropriate CNA blood pressure. CNAs will only inflate the dial up to somewhere between 160 and 180. CNAs do not go over 180. When we inflate this, what it's doing is putting air into the cuff and squeezing the arm. And if you've ever had your blood pressure taken, you know that hurts. What effect do you think pain has on blood pressure? Makes it go up. So if we just inflate, and we get that needle to go all the way up to somewhere in the 200s, you are inflicting a lot of pain on that patient, which is going to raise the blood pressure. Now, we might get a high blood pressure, but did they really have a high blood pressure, or was it because we overinflated the cuff? We don't know. So we didn't get any useful information here, right? So as CNAs, we only go up to 180. That's it. That's our stopping point. If the blood pressure is over 180, that's not normal. Who does that? The nurse. So we just go to find a nurse. We say, hey, blood pressure is over 180, and watch them run. Not our problem. Got it? So what's our stopping point?
180.
180. Don't go over 180. It hurts. Okay, we're looking for an abnormal. The patient's already abnormal. They found the abnormal. That's no longer us. We do normal. Got it? So we're going to inflate this cuff. The needle's going to go up to somewhere between 160 and 180, somewhere in there. And then we're going to start deflating it, and that needle's going to come down. And as that needle comes down, it's going to be quiet. Quiet, 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 still quiet, still quiet, still quiet, still quiet. Nothing happening, and your brain is going to be freaking out like, oh my gosh, I don't know what I'm doing. I'm missing something. I'm not hearing a thing. You're not supposed to. What we're listening for is the first thump. The first means there's nothing before it. Quiet, 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 thump. First thump. Where the needle is, when we hear the first thump, whatever number that needle is pointing to, that is your top number of your blood pressure. Where the needle is when we hear the first thump is the top number of your blood pressure. And remember, normal is between 100 and 119. So we are inflating to 180. There's a whole lot of quiet between 180 and 120. Got it? So we inflate, we deflate, we listen. It's going to be quiet. We listen. Still going to be quiet. We still listen. Keep listening, keep listening, keep listening, keep listening until you hear that first thump. Then we're going to hear more. Thump, 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 thump. We don't care. Doesn't matter how many there are. It doesn't matter when they happen. We don't care about any of the others. What we're listening for is the last clear thump. Not a shadow of a thump, not a ghost of a thump, not a, I think that might have been a thump. Last clear thump. And wherever the needle is, the number that it's pointing to, when we hear that last clear thump, That's our bottom number. That's all a blood pressure is. We inflate, we deflate, we listen for the first and the last. Those numbers are the blood pressure. It's not hard, but it takes a lot of coordination. Okay? It takes a lot of coordination to make this happen. The biggest thing to remember is that when you inflate, you're not going to hear anything right away. If you do, that means top number somewhere over 180. Go find a nurse, let them know. Okay? We don't need to know how high is. High is high. Got it? Okay. So inflate, deflate, listen for the first, listen for the last. All right. So we have two pieces of equipment to make this happen. So go ahead. If you've got your blood pressure cuffs and stethoscopes in your kit, go ahead and pull them out. If you have a little extra pieces, parts thing, just leave it in there. We don't need it. Let's talk about the blood pressure cuff first. All right, let's go back here. All right, when you're looking at the cuff, you've got the gauge, and the gauge is heavy, guys. Feel how heavy this gauge is. It's heavy. Those of you who need to assemble, just plug the gauge into either tube. Plug the bulb assembly into either tube. It does not matter. There's no right or wrong. What's that? You're going to need a cuff, too. You're going to need a stethoscope, but you'll also need a cuff. It doesn't have to be a set. You can get the cuff separate. We have them next door. All right. So this gauge, heavy, has a clip on it. You press down on the bottom of the clip, the top magically opens. Ta-da! On your cuff, you have a fabric tab of some sort. If you open the gauge and slide it up that fabric tab, it stays there. You want it to stay there. This thing is heavy. If you don't have it attached to your cuff when you're putting this on and off the patient, if you're just using these little prongs and setting it there, when you put this on and off the patient, it falls. If this hits a wrist, it can shatter it, especially if your patient has osteoporosis. You always want to make sure that your gauge is firmly attached to your cuff when you're putting it on and off patients. Okay. You also have below that a little artery marking. Now, it may be a line with a circle. It could be a patch like this that says right arm, left arm, but you have an artery marking. The problem is that this cuff has no brain. It can't tell you where the artery is. You have to put this over the artery. Now, remember, we're going to listen for a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound, guys. Not a big sound. So we want to be over the artery. If I've got a microphone here, you're going to hear me fine. If I put the microphone way over here, it's not going to be as effective. I need to be over the artery. So that means that I've got to find the artery and then position this over that. So to find an artery, if you stick your arm up, palm up, get that elbow popped out. You don't want the elbow down. I'm going to show you why in a minute. Get that elbow popped out at the fold of the elbow. On the pinky side, 2 fingers. Remember, don't use your thumb. 2 fingers. Put your fingers there. Put your thumb on the back and see if you can feel your thumbs. Usually it's not in the middle. It's on the pinky side. See if you can find your thumbs. Feel your thumbs. Everybody feel your thumbs? Can everybody feel thumbs? No thumbs? No thumbs? Okay. Right there. Right there. Press a little harder. Find it? Find it? Come a little bit further this way. Remember, it's on the pinky side. Got it? Got it? Okay. So, okay, we want to be up at the lines, not down here. You got way more tissue here, so we want the thinnest tissue we can get. Yours are very deep. Wow, yours are right there. Yours are very deep. Oh, yours is good right there. Put your thumb on the back. Holds consistent pressure. Anybody over here have trouble? Did you get it? Okay. Did you find it?
Yep.
Everybody find it? No? Okay. So we want to get our arms straight. Straight, 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 straight. That's right. Right there. Right there. Wiggle your fingers right, left, and center. Just right, left, center. Got it? Okay. All right. So now if you've got your artery there, right, you find your artery. Keep your arms straight. Once you have it, I want you to relax your elbow for a second and see what happens to it.
I can't feel it.
Yeah, you can't feel it. That arm has to be completely straight with that elbow popped out. What that does is it pushes that artery to the surface so you can feel it a little bit better. So what position do you think that your patient's arm needs to be in for blood pressure? Yeah, elbow popped out. Okay, good. Makes sense. So what we used to do is take a pen. Where's my pen? We would take a pen. We would find the artery, and we would take our little pen and write a little X marks the spot. So now we know where to put our stethoscope, right? We that's the artery. That's where we put the stethoscope. Your patients do not want you marking on them with pens, right? No X marks the spot. So what they did instead is they put an artery marking on your cuff. So if you lay the cuff on the arm, don't do this on you. I'm just going to show you real quick. But if you lay the cuff on the arm and you find the artery, okay, this is my left arm. So I'm going to line that arrow up with where I felt that artery. And now I know I don't have to find the artery again. The arrow tells me where to put my stethoscope. Okay. So it's an X marks the spot.
Where it's at, and then the stethoscope just goes here.
Right. Now, you don't want to tuck your stethoscope underneath the cuff. You want the cuff above the fold of the elbow. You want at least an inch there. And the reason is if I've got a microphone here, you're going to hear me fine. What happens if I do this? What happens if I cover my microphone? It muffles it. It flattens the sound or deadens the sound. Well, when you put your stethoscope, which is a microphone, underneath the cuff, that's what you're doing. You're flattening that sound. And it's going to be way harder to hear and way less accurate. So you want your cuff above the fold of the elbow. When you secure the cuff, you want it to be snug on the upper arm. You don't want it to be able to slip up and down. You want it snug. Good? Make sense? Okay. Now, at the bottom, you've got this bulb and valve assembly, and this is how we're going to put air into and take air out of this cuff. Do not inflate this cuff unless it's wrapped around something. If you just keep this cuff flat and you start pumping it up, there's nothing, this balloon has to press against something. If there's nothing, if it's flat, it's not pressing against something, and you'll actually throw your cuff out of calibration. And you can actually ruin the balloon inside as well. So you have to make sure it's wrapped around something. Now, when you go home and practice, if you take a can like this and you wrap your cuff around your can, just like this, you can practice working your bulb and valve assembly. So the way that I do this is this dial faces me, the bulb in my hand. When I have this dial facing me, now I'm going to turn around so you guys can all see. Okay. So if I have, I'm going to try to get this on screen here. If I have this dial, this silver thing facing me, this is my gauge. I'm going to turn this dial to the right. Right. Righty-tighty, lefty-loosey. Right? Righty-tighty. But just until it stops, I don't want to tighten it because I'm going to have to loosen it very quickly. So I'm going to turn it just until it stops. And then I'm going to squeeze my bulb until my needle gets up to somewhere between 160 and 180. I'm going to hold this dial between my thumb and forefinger, and I'm slowly going to turn that to the left, slowly, so that needle comes down. Slowly. That's a little fast. So let me do this one more time to show you. Okay, can you see it? I know it's a little blurry. See it on the screen? Okay, here we go. We squeeze our bulb, and then we turn the dial just a little bit to the left, little bit, so that it comes down like that. And we want it to come down all the way to 0. Now I have to keep opening, keep opening, keep opening, keep opening, keep opening, keep opening, keep opening. It's not a crock pot. You can't set it and forget it. So this, when you go home to practice this, I want you to put your cuff on a can and practice inflating and deflating a couple times before you move to live victims. Okay. All right. So this bulb and valve assembly is important. This is how we're going to control air going in and air coming out. That little silver dial, when you put it between your fingers, don't let go. Because if you open it a little and let go, when you try to touch it again to open it a little more, you'll end up opening it too much. So in order to have control over it, when you're holding it, hold it. Okay? Good? Questions? So this is how we're going to put air in and take it out. Clockwise to close it, counterclockwise to open it, or righty-tighty, lefty-loosey. So once we close it, we're going to squeeze it until our needle gets up to 160, 180. And then we're going to deflate it all the way down to 0. And when we do that, let me show you what's happening inside the arm. We have an artery inside the arm, and the cuff is wrapped around that upper arm. And when we put air in, that air is going to press inward and close off that artery. So it ends up looking like that. We're closing the artery. When we open that dial and the air comes out, it's going to open that artery up gradually. So right now, our dial is at 180. Our cuff has completely closed off our artery, and we've got some waves at the top waiting to come through. As we deflate our cuff using our bulb and valve assembly, that needle is going to come down counterclockwise, and that cuff is going to open up, that artery is going to open up, and some waves are going to be able to push through. Now, we're listening with a stethoscope right over that artery. As that first wave comes through, we can hear it hit the top of the artery. It's going to sound like a thunk. Where the needle is, when we hear that first thunk, is our top number. So if you're looking at this, where that needle is, that's 108, by the way, that is our top number. Once we hear the first one, we're going to hear more as the waves start moving through. Okay? As the waves start moving through. So the first thunk we hear is our top number, or systolic blood pressure. As more waves move through, you're going to hear more thunks. We don't care about those. What we're listening for is the last clear thunk. And that's because the artery is now wide open and the waves are moving through and they're not hitting the top of the artery anymore. So that is our bottom number. The last clear thump that we hear is our bottom number. So this one would be 78. Okay. So last sound means there's no more after it. The last clear one is the one that we're looking for. So this blood pressure reading, 118 over 78. 118 was where we heard the first. 78 was where we heard the last. We'll keep deflating until the needle reaches 0, and then we can remove our cuff and our stethoscope and record our readings. So the number where we heard the first thunk is our top number. In this case, it was 108. I know the last slide said 118. That was wrong. 108. And the last thunk was heard at 78. So now we need to learn how to read this dial. So if you're looking at the dial, you'll see it's marked in 20s. We've got 20, 40, 60, 80, 100, 120, 140, 160, 180, and so on. The big lines in between are your 10s. So this is 20, 30. Even though 30 is not marked, this big line is 30. 40, 50, 60, 70, 80, 90, 100, 110. Little tiny lines in between are 2s. So if this is the line for 60, that means this is 62, 64, 66, 68, 70. Little lines are 2s. That's what the next slide is going to show us. Little lines are 2s. So we're going to inflate to 160, 180, deflate slowly. Listen for the first thunk, which is our top number, our last thunk, which is the bottom number, deflate to 0, and document. That's all there is to blood pressure. It's not hard conceptually. The problem is it's hard physically because your hand is inflating and deflating, right? So your hand has a job to do. Your other hand is holding your stethoscope, so it's busy. Your ears are listening for those thunks. Your eyes are watching the needle, paying attention to where we heard the thunk. So there's a whole lot going on, right? Whole lot going on with this, and it takes some time to kind of get this dialed in. You're going to feel when you first start this like you need at least one more hand. Like I could do blood pressure if I had just one more hand, but you don't. So you have to learn how to work with what you've got. Okay. So to recap, we're going to inflate up to somewhere between 160 and 180. We're going to deflate and it's going to be quiet. Where we hear the first thump is our top number, whatever number the needle's pointing to. Where we hear the last thump is our bottom number, whatever needle number the needle's pointing to, and then we deflate to 0. That's how we take a blood pressure. But we have to learn how to use our stethoscope. And this is actually the most critical part of this because nobody uses their stethoscope right. There is a right and wrong way to do this, and guaranteed you've probably been doing it wrong. So let's get into this. Stethoscope.
I have a question. For the
Yes.
state exam, we're not being tested with blood pressure. We'll be tested at taking pulse. Are we to bring our own, or we're using?
No, you're not. For pulse, you don't need any equipment.
We don't need anything.
No.
Okay.
No, for pulse, you're just going to use your fingers.
Okay.
Yep. So you don't need to take a blood pressure cuff or stethoscope with you to the test.
Okay.
Nothing like that. So let's talk about the stethoscope now. Blood pressure cuff is way easier than the stethoscope. So let's talk about the stethoscope. This end is a microphone. That's all it is. It's a microphone. But the problem is that we don't want to amplify everything. We only want to amplify what's happening inside the artery. We want to hear the wave of blood hitting the top of an artery. If this were an omnidirectional microphone where it picked up everything, you would hear the fans spinning. You would hear the AC kicking on. You'd hear people's feet. You'd hear my chair squeaking, right? You'd hear all. We don't want all of that amplified. We only want one side amplified. So this has an on and off side. there's two sides to the stethoscope. These are diaphragms. If they're flat, they're diaphragms. If they're kind of bell-shaped, they're called bells. But there's two sides. This whole thing turns. The whole thing turns. We have to tell the stethoscope which side we want to listen to. Now, as CNAs, we only use the large side. We don't need the small one. This is for high-pitched sounds, something we don't do, lung sounds, heart sounds. So we only use the large diaphragm. That means that we have to tell this stethoscope which side to be on. So if you look at this, up at the top where this joins, you see a dot. You guys see that dot? Okay, if you've got one like mine, like this, you'll see a dot. Okay, the large diaphragm has to be on that dot side. The dot is what's on. So if yours looks like this, right, where your dot and your large diaphragm are on opposite sides, you just have to turn it.
Mine doesn't have that. Mine doesn't have
If you don't have a dot, flat, if it's flat, that's your on side. So turn yours completely around. Yep. Yours is single, it does not turn. Yours is single, it does not turn. Yours turns. You have a dot. You should have a dot.
Yeah, I have.
Okay. You should have a dot. You should have a dot. Everybody else good? Everybody else good? Okay. So we want to make sure it should not look like this. Okay. See how the small diaphragm is facing the dot? Ours, the large diaphragm, should be facing the dot. Now, I bring that up because when you guys go to put these in your case later, do you know what's going to end up happening? It'll turn. So when you take it out, always make sure your large diaphragm is on the on position. But believe it or not, this is not actually the most important part, although it is important. This is your ear tips. Your ear canals are not straight in. They're not. Your ear canals are actually curved forward, and we've got to have our stethoscope in the same position. Now, most of yours are already preset. Do you see how mine are kind of facing, kind of positioned a little bit forward? Yours are preset. Yours, and yours are preset. Yours are you're going to have to turn. Yours you're going to have to turn. Yours you're going to have to turn. Yours are preset. Can you hold yours up for me? Yours are preset. Yours you're going to have to turn. Yours are preset. Okay, so those of you who have to turn, if I pointed to you, okay, we're going to manually adjust them. So if your earpieces are slightly curved in one direction, you're okay. Everybody else, if you've got straight earpieces, we have to turn them. And this is how you turn them. You hold down here at the chin strap, and you just turn your earpieces a little bit. Not a lot, a little bit. We're looking for something like this. Okay, something like this. Now, how you put these in actually matter. They need to go in facing forward. Do you see this diagram, right? If you put them in backwards, you're not going to hear. So do you see how these are facing away from me? Facing away from me. So turn your whole thing, just turn the whole thing like this. There you go. So they need to be facing away from you. So turn your whole thing. Yep. They have to face away from you. So turn your whole thing. Yep. So you're going to put these in your ears and then tap on your diaphragm. And you should hear, right? Tap on your diaphragm. Now take them out. Turn the whole thing around so they're backwards. Put them in and tap on your diaphragm.
I don't think I was able to.
Okay, now put them back the right way. This is how you have to wear your stethoscope, for the earpieces facing forward. Okay. Remember, this is not a big sound. This is a teeny tiny sound. Teeny tiny sound. So if we don't have, let me help you. If we don't have, that should be good. Put them in like that. If we don't have our stethoscope facing the right way, we're not going to hear the sound we need to hear. Okay. So we have to make sure the stethoscope is facing away from us. This is a very, very common mistake with blood pressure. Now, you're not going to be able, if you just put your stethoscope in and put your diaphragm here, you're not going to hear anything because your artery is wide open. It's not, there's nothing hitting the top of the artery. There's nothing there to hear. Okay, so you're not going to hear anything because the artery is wide open. We have to compress the artery with a cuff for us to hear any thumps. So you're not going to hear anything. You have to find the artery with your fingers. And then you put the stethoscope there. We inflate, we listen, we deflate all the way to 0 and then take it off. Make sense? Good. Questions? All right. The arm, as always, needs to be supported. If you just have the arm hanging out in midair, it's going to make those muscles work harder. It increases the blood pressure. That's going to give us a false reading. So the arm needs to be supported on a table, a chair, a surface of some sort. Feet should be flat on the floor, not crossed leg over leg. Feet flat on the floor for a good blood pressure. Okay. So putting in the ear tips the wrong way is the number one mistake made on blood pressures. And you can be off by as much as 30 millimeters of mercury. 30. It's a big, big issue. Okay. Good. Makes sense.
So to just check it, you just can thump, and if you hear the thumps, then you know you've got it in the right way. I mean, if you just tap it.
Yeah. Yep. You can tap it to make sure.
Yeah.
Mm-hmm. All right. So to recap, we're going to inflate the cuff. We're going to deflate. We're listening for the first thump, the last clear thump, deflate all the way to 0, and then take your stethoscope off and your earpieces out. Remove the cuff. When you're taking blood pressures, guys, only take it twice on one arm, then move to another arm, then move to another patient. Because you're not getting it, and that's okay. Not everybody has a good, easy to hear blood pressure. But if you take the blood pressure over and over and over and over and over and over and over in the same arm, remember, we're cutting off blood supply to that arm. We're using air to press that artery closed. And we can actually damage the patient by taking the blood pressure over and over and over and over and over again. So we want to make sure that when we're practicing at home, we're keeping our loved ones safe. Twice on one arm, move to the next arm, move to another patient. Okay. Don't keep trying to do it over and over and over. Friends, family, neighbors, anybody you can tackle is a good person to do a blood pressure on, but not on kids. Nobody under 13. This hurts little arms. You'll make them afraid of medical people. Don't do that. Nobody over 80 either. They got their own health problems. Leave them alone. Okay. But the other thing is that, remember, CNAs follow the care plan. So our care plan is going to tell us how often we should be taking blood pressure. We don't get to decide that. We don't get to decide, okay, I'm going to take your blood pressure every 5 minutes. That's not something that we just follow the process that's laid out for us. If we get something abnormal, what do we do with that information? Tell the nurse. You start to notice the rules are all the same. It doesn't matter what the skill is. Okay. So being a CNA really isn't all that difficult. You're going to do what the care plan tells you to, and then anything else you just report off and let the nurse deal with it. Okay, good. Questions on this? All right, let's look at page 57 real quick. The gray box there. Now, so far I've called them thunks. They actually have a name. They're called Korotkov sounds. You don't need to know that, but they do have a name. Korotkov sounds. But if you look at the gray box there on page 57, number 8, it shows you 2 arrows there. It shows you or 2 lines, where the first thump was heard and where the last thump was heard. Can you guys tell me what this patient's blood pressure is? Number 8. 130 over 90. Is that normal? So what would we need to do with that? Tell the nurse. Let's go to number 13. Or I'm sorry, 10. 10. What is the blood pressure for that one?
108 over 61.
Yeah, remember each one of those lines is 2. So 108 over 62. You got something in that ballpark? Is that normal? Okay, so we would just document that. But what if you went to document that 108 over 62 and you noticed all the other blood pressures were super high?
And that's uncommon for that patient. That's pretty rare.
Okay, we would want to notify the nurse. Yep. That patient might actually be having an internal bleed. First sign of an internal bleed is a drop in blood pressure. Okay. Good. Questions? All right, I want you to break up into groups of 2. I want you to practice blood pressure and let them practice on you.
Ready, Maria?
Sure, absolutely. Absolutely. You can borrow this one now if you want.
Okay, no, hold on. You want me to
I could rest it there.
Switch it out, so that's why I'm not opening it.
That's fine. Yep, no problem. Just leave that on there.
Yes, I'm just watching to see how.
Oh, okay. Yeah, it's see, it opens at the top. Yep. Just slide it up there and it'll stay. Yeah, we need to go up a little bit because you want this area clear.
You're doing a good job putting it on. That's the tricky part, too, putting it on.
Yes, it is. Like I said, you're going to feel a little unsure of yourself at first, and that's okay. I am here. Yep. Okay. So we're going to take this cuff. Okay, yours is a slide on. That's why. Okay. So we're just going to slide this up the arm. Okay, we're just going to lay it in place. We're going to find the artery, which is right here. Yeah. We're going to put this over the artery. And remember I said that we don't want the stethoscope under the cuff. This is a home cuff. It's for you to be able to take it on yourself, and you don't have enough hands, which is why this is like this. Okay. A professional cuff you want to have up a little higher. That's fine. It's okay to practice with. Okay, you're going to want to put these in your ears, facing away from you. Yeah. Yep. Now you're going to hold that in your dominant hand. Yep. Turn it all the way to the right. Yep. And then squeeze.
It's okay. You're going to squeeze the ball to get it to one ear. You might have to tighten it sort of.
I think it's right here.
You're going to put that one up. You got to tighten it. Okay.
Okay. And now open it just a little bit, a little tiny bit, and listen.
Okay.
I'm so sorry.
Keep opening.
I lost that last thought. I got the first one, but I didn't.
Okay, did you hear thumps? That's
Yes.
all I care about today. Did you hear thumps?
So we don't have to actually try one.
Yeah, just hear thumps. All I want you to do is hear thumps.
But that's okay. But can you say some? Okay. It is a little tricky. We could go again if you want. We could go twice.
You wanna try?
She said you don't have to worry about the numbers. Just so you're hearing the something.
And then I'll do one of you guys.
You're not going to hear anything yet.
Oh,
You're not going to hear anything yet.
you gotta use
Yep. But let me help you with this real quick.
how
Okay.
long?
Yeah, let me take this off. I'm gonna put it on this way so the tubes are down. Okay. And see our artery marking? That's the artery. Okay. So you can place your stethoscope here. You're not going to hear anything yet. Are you right-handed or left-handed? Okay, so yep, switch your hands. Okay. So we're going to squeeze until this gets up here. We're going to close this off. Okay.
The bulb is tightened around the arm.
Okay. Now let go. You're going to open this dial just a little bit. Little bit. There you go.
Yeah, you're welcome. Oh, really? You totally get shocked. Really?
Keep opening a little more.
I find it very awkward.
A little more. A little more. A little more. Other way. Other way. There you go.
No, they do. They spell other ones.
Did you hear thumps?
Yeah.
Okay. That's all I care about right now is thumps. Okay. Hold on a second. Hold on. We have to turn it this way. Yeah. And then you're going to squeeze. Nope. You want to hold it this way. Squeeze. Okay. Put your stethoscope here. Okay. Yeah, that's good where it's at. Now open this just a little bit. Little bit. Little. Did you hear any thumps? Okay. Let me do this for you. This part for you.
Oh yeah.
Take your earpieces out for a second. I think they're nope. Take them off. I think you got them on backwards. Yeah. They've got to face that way. Okay. So go ahead and put those in. Put your stethoscope here. I'll do this part for you. I just want you to listen. You really want to sandwich that in. Get a good seal on it.
Alright, so I'll try. Who am I trying?
Now just listen.
Did you hear something? Okay, it's hard. It is to get used to hearing it. It's especially hard to hear that second one as it starts fading away. To hear the last one.
And also, like,
Yeah, I heard
everybody's
one.
like talking.
I know, right? That doesn't help.
No,
Yeah,
it's
everybody's
the second
talking,
one.
especially the patient.
Around like 90.
Did you hear thumps?
I was so
I didn't hear the one all the way.
Okay. But you heard thumps.
Yes.
That's all I care about
Yeah,
today.
and then
Right?
it taper off to nothing.
Right.
To the last thumb.
Right.
Okay. To the first thumb, and then it taper off to the last thumb, which is the bottom number.
Bottom number. Yep.
All right.
Yeah. Okay. All right. I'll help you.
How do you find out again? On your arm?
So it's on the pinky side.
Pinky side.
Yeah, right in here.
Right in between there?
Yep. Okay, watch what my fingers do.
Okay.
I used to love
See how I'm
this
going
one.
back and forth and then
Yep.
settle in the
Too, I
middle?
love how my
Yours is pretty
pieces-
deep. You've got a lot of tissue
Yeah,
above
then
it,
you get switched,
so it's a
right?
little bit,
I
a
don't
little
know.
harder
I
to
got this
feel.
here, so I didn't do any other thing. So I don't know.
I don't know, then maybe I might be wrong because I thought it was those that you could switch.
Go ahead and
every
find it on
one
yours.
day.
Some people are a little easier to find than others.
Yeah, I have one of them. I should have put them in tank top on her. Should have allowed me.
Okay. Yeah, it's not big. Okay.
Well, I heard the last one, didn't hear the first one.
Open it all the way up. So, yep, it relieves the pressure.
So I didn't hear the first one.
Okay.
I heard the last one.
Okay, that's good. That's good. Okay. So let me work with you real quick. Okay. We'll do hers because that way I'm closer. So let me see this real quick. Okay. So we're going to find the artery, which is right here. Okay. We're going to secure this. Put your stethoscope in. There you go. You're going to put it right here. I'm going to work this part, and I just want you to listen, okay?
Sorry.
You're on in your badge.
Yes, you got good deep.
William?
Yeah, I could hear that really well. Yeah.
Didn't hear anything? Okay, hers may be difficult to hear, possibly. Let me see your arm real quick.
Is it closed out the way?
Right is all the way, right?
Okay. So again, you're going to be right here. Let's do something real quick. Yeah, that's right. Okay, go ahead.
I let it go a little too fast. So I can tell you got a really good heartbeat. I really do have a
I wanna,
Her both were.
well,
You wanna do it again?
maybe somebody else.
It
Because
was like
I
a
can,
little bit over.
she said that if you try 2 times and you don't get it.
Don't worry about it. You did it first time. So you did it first time.
Yeah.
Don't worry about it. It's okay. I'm a good.
Okay, good. Good. You guys okay?
Well, I
You have a good strong heartbeat.
think it was around the same shooting time. It was like, oh my
Yeah,
gosh.
that's good,
Yeah, the
honey.
second time I took it was definitely higher than the first time.
Each time you take it, it's actually going to go a little higher because you're putting stress on the arm and that causes more blood flow. So it actually increases the blood pressure a little bit. Okay. Okay, go ahead and wrap up the blood pressure that you're taking.
Look at you go. Good pro.
She wants to wrap up the, try to.
Did you hear it come?
Mine's very helpful.
Well, honey.
Yeah, yours is good for self blood pressure. That's why the stethoscope is attached. You can use it to practice. It's okay.
Is your mom a nurse?
She's actually in Langston's and a legal nurse.
Nice.
She used to do RN. She used to do critical care.
Oh my goodness. She's well experienced. I bet she's glad you're following in her footsteps.
I'm sorry.
But she's glad you're following in her footsteps.
I am a little bit. I just don't know what I'm gonna do yet.
Yeah, that's okay.
All right. So did everybody hear at least one good set of thumps? So you know what you're listening for to practice. The only way to get good at this now is to practice. Yeah, that's really the only key to this. And remember, it's not on the state exam, so that's take some of the pressure off of yourself. But you do need to learn how to take a good, effective blood pressure.
So they will ask us questions. They can ask us questions.
Yes, they can ask you procedural questions as well as normal values. Yes, you still have to know those normal values. Absolutely. Homework, you're going to be reading chapter 4. We did talk about that a little bit at the beginning of the class. Remember to pay attention to the changes of aging with each body system. I will be reviewing that with you at the beginning of the next class. Okay. So I'll kind of go over, I will summarize everything you need to know out of chapter 4 at the beginning of the next class. Next class is Wednesday. Remember that you will get a follow-up email, wrap-up email from us today. If you have claimed the online course, I have a whole lesson in there on abnormal values, which will help you kind of identify normal and abnormal. And it's a fun activity for you to do in the online course. So I would definitely check that out. Other than that, you'll want to grab class 3 review sheet on your way out. It's the light blue one in the document holder. And on the next class, on Wednesday's class, we will be going through the state test applications, and I'll be handing them out to you. We'll be filling them out in class together so that you know what to put where, but you will be registering on your own when you're ready to. So you don't need to bring the money to class or anything like that. You'll be registering on your own, but we will go through all the paperwork together.
Is it online registration or?
They're both. I'm going to give you the actual registration paperwork, but you can register online. It's the same form. We're going to fill it out together so you know what to put where. Okay. You don't need to. You do not need to bring your stethoscopes and blood pressure cuffs back to class. We won't be going back over blood pressure. But if you want extra practice, you've got, 13 willing victims sitting here. So you are welcome to bring them back to practice, but we will not be going back over them. All right. Have a fantastic day.
Wednesday?
I will see you guys on Wednesday.